Good morning, everyone. I welcome all of you in this webinar on hospital infection control. This is a very important aspect of our healthcare organization. This hospital infection control, if we are taking care of this, we can avoid many problems or many infections which otherwise patient may get while visiting hospital, and we can also keep ourselves also safe from getting these infections. This program is accredited by Delhi Medical Council. You will get 1.5 hours of credit point. People who are member of any state medical council, they will get certificate with 1.5 credit hours. This will help us. This will help them in getting their registration with the state medical council renewed. But for this, there is a mandatory requirement. During the program, we will post time to time one registration form. Although you have filled one registration form, but this information will be sent to Delhi Medical Council, then they will approve the certificate. So it is mandatory to fill this registration form to get the certificate. And also we will post one feedback form. Filling of that feedback form is also mandatory. So please remember, during the program, we are starting this program at 10 o'clock and we will continue with this program till 2 o'clock. After every half an hour, we will post registration form, but you have to fill only once this registration form and feedback form. But filling is mandatory to get the certificate, and you will get the certificate with credit points. Now to discuss this healthcare associated infection and its prevention, today we have with us as faculty Dr. Upasana Bhumbla and Dr. Suchitra Jain. First, Dr. Upasana will start. Dr. Upasana is currently working as Associate Professor in the Department of Microbiology, Adesh Institute of Medical Sciences and Research, Bathinda. She has done a lot of research in microbiology. She has vast experience in delivering talk in various national platforms. And she has also written a book on competency-based practical manual for microbiology. This is very useful book for undergraduate and postgraduate students. And also this book will help practicing doctors also in clarifying various doubts related to practical aspects of microbiology. So now, without wasting any time, I will request Dr. Upasana. It is already 10 o'clock. So please start with our presentation.
Good morning, sir. Good morning, everyone. Thank you so much, sir, for giving me this platform to deliver this lecture on healthcare-associated infections and its prevention. We'll be talking about healthcare-associated infections. What are the definitions? What is the infection control team? What is the hospital infection control committee? What are the prerequisites? What are the indicators? What are the surveillance criteria? So these all we'll be dealing up in another next 1 hour with you guys. So talking about what are healthcare associated infections, I think nowadays everybody might be aware of the word. Pehle word use hota tha nosocomial infections, then came the word as hospital associated infections, and now the word has been changed to healthcare associated infections, or the HAIs, which is readily used, I think, in everybody's system. Which defines as the infections in the hospitalized patients which were not present or which were not incubating at the time of admission. So in a brief way, if at all I can describe it, if a patient is admitted to our hospital with an X disease, and during the time of incubation and during his presence in the hospital beyond 48 hours, he has developed a Y disease given by probably the hospital setup or the breach in the practices, or there is any delay in the practices which would have led to this hospital acquired or the healthcare associated infection to the person. So an infection in a medical setting in the course of medical treatment is nothing but the healthcare associated infection beyond a period of 48 hours. Okay. Talking about brief about the history of mankind, how it started, the existence, about the antiseptic procedures, the people who were associated with the antisepsis. I think the world knows about it. We know about Semmelweis, we know about Louis Pasteur, we know about Robert Koch, Florence Nightingale. They all worked for infection control practices and for the development of setting up the prevention practices required by the hospital setups. So yes, Joseph Lister was the father of antisepsis, who gave us the word, who termed the terminologies. Joseph Lister for almost a period of 1827 to 1912. Then we had about Semmelweis, which was almost there up till 1865, a very famous physician who worked for the antiseptic policy and for the hand hygiene practices. We have the word of Louis Pasteur, we have the word of Robert Koch. I think these two pioneer people who started with the work in microbiology. Louis Pasteur, he having the history of how he developed his interest in microbiology and infection control. As in, he had 5 kids, and out of that only 2 could survive. So 3 died of some diseases which were not known to him. So that was his history of how he developed his interest towards dealing up with infections and to find out the diseases. Then we had the history of Robert Koch, who said that yes, definitely hello, can you hear me? Please, anyone, please admit yourself and let me know if I'm audible.
Yes, Upasana, you're audible.
Right. So I was talking about Louis Pasteur and Robert Koch. So these were the pioneer people who worked in the infection control policies, and infection control team and the infection control committee works basically in developing the policies and procedures which should be designed for a particular hospital. Okay, moving on to the infection control program, it develops at 2 areas, that is at the executive body and the advisory body. I think the word itself says it, the executive body, which is the core people who work on day-to-day basis, and they help in developing and knowing about the infection control practices and the breaches where all it is happening in the hospital area. The major part is the advisory body. Again, the word itself can explain it. Advisory body is nothing but the people who can actually formulate a complete committee and who adopts the legislative role for making up the policies and the procedures. Okay. So hospital control program, it has got 3 components: the hospital infection control committee, that is the HICC. Then we have the infection control team, that is the ICT, and to formulate an infection control manual. I think the word manual itself describes it. It is a procedural book. It is the SOP of the day-to-day activities or the routine activities which should be happening in your particular institution. The policy making, the legislative roles of various people who are there in the committee, what all they are supposed to do. Then about the vaccination, about the outbreaks, about the annexures, about the needle stick, about hand hygiene practices, about the quaternary ammonium compounds, the various products being used in your institution. It should be documented. The proper SOP, standard operating procedure of your hospital, should be written up. So first of all, talking about the infection control committee, I think everybody needs to know when we are talking about the infection control and the infection control practices, an administrator, definitely we don't have the idea, the ideology of how the committee or how the team should work, right? But everything we require a leader. So in a committee, if we are talking about the hospital infection control committee, it is mandatorily that we need to have a chairperson, which has to be a hospital administrator, not anybody from the other areas, but of course, an hospital administrator can only be the person who can lead the infection control committee, who could be an ideal chairperson for the HICC. So talking about in my institution, yes, we have a medical superintendent who is the hospital administrator, who is the chairperson of our hospital infection control committee. Moving on, next is the second most important point, or the person who is involved in HICC, that is the member secretary of hospital infection control committee. Again, without a doubt, it has to be a person from a head of microbiology or the in charge of microbiology should be an ideal person who should be labeled as the member secretary for the hospital infection control committee. People ask me, ma'am, how can you say that the member secretary has to be a microbiologist? If we talk about infection, if we talk about infectious diseases, yes, ideally, all the culture reports, all the variable organisms which are prevailing about the antibiotics, about the antimicrobial stewardship, I think a microbiologist has to play a very, very important role. And that is why he or she is the key person as the member secretary in the hospital infection control committee. Then third person is the clinical microbiologist, or we label it as the infection control officer. Here, there are points when we talk about the member secretary is already a microbiologist. Can we have somebody from ID? Yes. Person from infectious diseases or anybody from microbiology can be an infection control officer. So these three are the key positions which cannot be changed, which cannot be replicated at any point. So hospital administrator being the chairperson, member secretary as the co-chairperson or itself as a member secretary in the HICC. Then we have the infection control officer or the clinical microbiologist. Fourth, or the most important person, sometimes sublimed over the ICU or the member secretary, that is the infection control nurse. But let me tell you, or together if at all I can put up, without this person, without this man or lady, whosoever is the ICN out here, they play a very important role, because at the ground level, whatever is happening, they are the key resources who can update us as a member secretary or an administrator what all is happening in the hospital, where all the breaches are taking place, and as an administrator or as a member secretary, what all precautions or what are the steps, measures you can pick up. Then comes the team of all the HODs, which includes a person from as a journal physician, journal surgeon, all the HODs of the super specialties if it's a super specialty hospital. Then director of nursing, of course, they are the people who can bind all the nursing staff and help us in building up a strong infection control team. Then occupational health physician, as I said that, either as a clinical microbiologist or as an ID specialist can be one of the person who can be there as infection control officer. Representatives from all the clinical specialties, we already spoke about it. And of course, we have to mention it out here. So additional representatives of any other department, it can be from the operations that deal with the day-to-day activities, pharmacy, listing about all the antimicrobials we have, how much is the use which is happening, and how much is the drug overdosage, over-the-counter supplies. I hope it is not being done in our institution. A person from CSSD, the one who packs, the one who picks up all the relative material and then ETO or sterilize and give it back to our OTs. Then team from maintenance, if any breakdown is there, if any mishappening is there, people from housekeeping, people from fire, safety, or people from F&B, that is food and beverages area. So all these people, they hold a very key role in formulating an infection control committee. So any hospital who is developing an infection control committee or who are planning to formulate an infection control manual or infection control team, these are readily important areas that where, yes, we should talk about. One, we having an administrator who can work as a chairperson. Second, we need to have a member secretary and the infection control officer who can work on the breaches or the practices, how to be evolved. And third one, the infection control nurse, which does the day-to-day activities, along with other these key members as physicians, HODs of all the super specialties, nursing superintendents, health physicians, or representatives from operations, pharmacy, CSSD, maintenance, and housekeeping. They all formulate a bigger area named as the Hospital Infection Control Committee, HICC. Another part of a hospital infection program is, one was HICC, now is the infection control team. As I just previously mentioned in my previous slide, saying that yes, the microbiologist, the infection control officer, and the infection control nurse or the nurses, we require one nurse at 250 beds. That is mandatorily nowadays as NABH standards. We need to have it. We have to follow this. So infection control team altogether with a member of almost 4 to 5 people with one microbiologist or 2 or 3 nurses, depending upon how much is the strength of your hospital beds. They are responsible for your day-to-day functions of infection control. One word about, before I start with the proper surveillance and the indicators, what are there. Here only I'll mention about the infection control manual also. So your infection control manual, as I said that in the starting itself, that yes, we need to formulate our policies and procedures, and it has to be documented, because even if it's NABL or it's NABH, everything is all about documentation. So what are policies you're following? What are the status of your various procedures, what you are following? That has to be documented and properly formulated in a procedural book, which is nothing but your infection control manual. And that infection control manual has to be, every year it has to be reviewed, or it has to be either with whatever changes you require. You can think about it as per your system and as per your policies. Again, it is not only the job of the infection control team, it is the job of the whole infection control committee to have a look in that infection control manual, do the prerequisites or the required changes, whatever is required, and with the acceptance of the whole HICC, your hospital infection control committee. And only the team cannot do that. The whole HICC has to sit together and look for the procedural activities, or if any changes are being amended in your manual, that has to be passed infection control committee, then only it should be further the version is given into it. Okay, very quickly, when we talk about the functions of HICC, so first and the foremost is about the HAI surveillance. We have the catheter associated urinary tract infections. Then we have the Centerline associated bloodstream infections. Then we have ventilator associated pneumonia. And lastly, we have the surgical site infections. We will be dealing about this HAI surveillance in detail in my next coming slides. Okay, beyond surveillance, what is the next step which actually HICC takes up? Yes, they have to develop the system of how to identify the errors, how to identify the barriers. When are you reporting it? How you are analyzing it. Finally, you have the you have the analytical, and how is the post-analytic area, that is the controlling of the healthcare associated infections, how you are taking it, and how you are developing a system to eradicate all the major problems which is happening in the system. So making policies for proper antibiotic usage, that is also a part of the HICC. Implementing an antibiotic stewardship program. Nowadays, emphasis are being taken on antimicrobial stewardship. We have antimicrobial awareness weeks also, which is somewhere in the 2nd or the 3rd week of November. Very actively, people are talking about it. Antibiotic stewardship, in a nutshell, if at all, right drug, right dose, and right time of to the right patient, if at all it is given. So scaling onto the goals, scaling onto the pyramid of developing an antimicrobial stewardship program, it is nowadays a very much important element for NABH standard to be raised up for a particular hospital. Lastly, talking about the outbreak management, I think the world is dealing with COVID since 2 years. It's been almost 2 years. We have spoken about COVID, the pandemic, how much mutant, how much variants, 3rd wave with this Omicron virus. And recently the news are coming with new COVID also at the new horizon, probably making the 4th wave of COVID. So outbreak management, that is also the key role, the key function of the hospital infection control committee to talk about it. Very briefly about basically in medical ICUs, we talk about COT, BAP and CLEP, and in surgical ICUs, mainly about the surgical site infections. So talking about what is surveillance, I think now that those who are taking up these indicators very seriously in their hospital infection control committees. So as I said that, yes, we have to develop a system where we are seeing it, we are taking into coordination, we are taking into accordance how the surveillance is implemented, how the dominants of variables are actually identified in our system. That is very, very important. So to define what is surveillance, it is a systematic method of, firstly, to collect. You have collected, how you are consolidating, and जो भी आपने डाटा कलेक्ट कर रहा है, how you are analyzing the data. These are the three main streams: collection, consolidation, and the analyzing of the data. And once you have analyzed, how much you have left for the improvement of all these analyzed data, how much practices, how much the prevention control practices you have taken up, so the outcome should be a healthy outcome, or there is no healthcare associated infections to the patients. Pardon me for my bad throat. So talking about first and the foremost, we have this catheter associated urinary tract infection, the first surveillance indicator, what I'll be talking today. To define COTI, we have a urinary tract infection wherein an indwelling urinary catheter is in place for or the 2 calendar days, and taken the day 1 as the date of the event. The day you are placing the device is nothing but your day 1, and beyond that 48 hours, where an indwelling catheter is already there, that is nothing but broadly you define as catheter associated urinary tract infection. Or there is another word named as SUTI, that is symptomatic urinary tract infection, and the other word is ABUTI, asymptomatic bacteriuremic urinary tract infection. So talking about SUTI first, symptomatic urinary tract infection, as the word itself is defining it, yes, it should need to have the criteria. Yes, the catheter is in place for more than 48 hours, taking the day 1 for the insertion as day 1, and at least one of the signs of sepsis, that is either fever with suprapubic tenderness, or gastrovertebral angle tenderness or pain, or the urine culture has to be positive with an organism with a significant bacteriuria. So these are the criteria for the symptomatic urinary tract infections. Talking about asymptomatic bacterial urinary tract infection, ABUTI, what I said, COTI is defined into 2 areas, SUTI, ABUTI. In this, the word is saying about asymptomatic bacteremia. So that was symptomatic, अपने आप से define कर रहा था. This is asymptomatic, with or without urinary catheter, and probably he or she might not have any symptoms, whether fever, whether urgency, whether dysuria or suprapubic tenderness. But there has to be a positive urine culture. The organism has to be present with a significant bacteriuria, and either with one organism or not more than 2 organisms can be labeled as asymptomatic bacterial urinary tract infection. So we had SUTI, we had ABUTI. What are the commonest organisms? I don't think so I have to define this. Yes, E. coli being the most predominant one, it is available. And when we talk about national Nhsn standards, there are Nhsn standards, but for India, as particularly it is said that there are no standard, but the studies are there, and in various studies it is saying that key standards has to be 1.6 to somewhere between 2.1. They are the standards, but whereas the world Nhsn standards, if at all we talk about, it might vary from 0 to 5.3%. That is again a documentation. There are no recent standards which has been given by any of the CDCs. So talking about common pathogenic organisms, E. coli being the most predominant one in gram-negative bacteria, and Coagulase-negative Staphylococcus and Staphylococcus aureus being the very predominant one in gram-positive organisms, which is very prevalent for causing catheter-associated urinary tract infections. So talking about the surveillance part, as I said that you are collecting, you're consolidating, and finally analyzing the data. First and the foremost, whose duty it is. The daily day-to-day activities, the bundle checklist has to be taken up by the infection control nurse, right? And then the whole data has to be consolidated and given the name of how you are analyzing. So COTI rate is defined as the number of urinary catheter days as catheter associated cases. Kitne cases aaye hain, divided, denominator has to be the urinary catheter days in that one particular month multiplied by 1000. So this is how you calculate the COTI rate. Moving on to the prevention core strategies and the supplemental strategies to how to avoid catheter-associated urinary tract infections. First and the foremost, at the pre-analytic area only, when you are inserting the catheter, what are the indications what you are giving for the catheter insertion? What about the patient, about the particulars of the patient? Is it a high-risk patient? Does he or she require? Is it a proper indication? or an immunocompromised patient, what is the criteria, what is the indication for what we are inserting the catheter in a particular patient? So you remove the catheters as soon as possible. At some places, when we talk about what is the consistency of the catheter is also very, very important, whether it's a silicone catheter or it's a rubber catheter, for how long we are supposed to keep it. Are we keeping it for 15 days? Are we keeping it for more than 15 days? So what all the criteria are, we should look for it, and based on that only, we should make sure how much is the required time within 1 week, within 2 weeks, how frequently we are removing the catheter for a patient. And when we are inserting it again you need to have one urine culture sent to the microbiology. I hope it is not any irrelevant flora which is already pre-existing there. So before labeling also, I need to mention here, before labeling also any patient as catheter-associated urinary tract infection, yes, the patient has been there with you for almost 48 hours with catheter in situ. So can we label it? So to justify that catheter-associated urinary tract infection, when you are inserting the catheter, at that point only the first urine sample has to be sent to the microbiology department. So if that is sterile and after 48 hours patient is developing, then only we can label the patient as, if you have not sent the preliminary sample, it is very difficult to identify whether it was actually COTI or it is already pre-existing UTI by the own person. Then talking about ensure that only properly trained persons insert and maintain catheters. Yes, that has to be the prerequisite. You cannot have one fresh trainee and directly dealing with immunocompromised or serious patients or critical areas where such requirements are there. And without mentioning, it cannot go away saying that aseptic technique, how well any trained person is doing it, whether he or she is performing the hand hygiene before and after the insertion, the 5 movements of hand hygiene, whether they were dealt or not, sterile gloves were used or not, sponges, antiseptic area, periurethral cleaning, single-use packet of lubricant jelly. So all these prerequisites are very much required as core and supplemental strategies for the prevention of catheter-associated urinary tract infections. Moving on, next we have the ventilated associated pneumonias. I think अभी आप लोगों ने बहुत ज़्यादा सुना होगा about ventilator associated pneumonias. About IVAP, we talk about ventilator associated events. So this is how a healthy or an infected lung looks like. Normal chest X-ray and a patient with ventilator associated pneumonias, how their lungs they look like. To define what is ventilator-associated pneumonia, these are nothing but PNEU word. आपने बहुत सारे papers में ये word देखा होगा. That is nothing but pneumonia. पहले VAP को label करने से पहले, it used to be called as only pneumonia, or with a ventilator also they used to label it as PNEU. That occurs. Any pneumonia which occurs beyond 48 hours of the patient who is already on endotracheal intubation, the patient is intubated. Again, here the first strategy has to be, you are labeling the patient only when you are sending the first, after the intubation, the first sample is sent to the microbiology lab without any delay, and that is sterile. And after 48 hours, the endotracheal secretions, what you are sending it across, that can be labeled as ventilator-associated pneumonias. So apart from that, we have presence of new or progressive pulmonary infiltrates on X-ray chest. What is it labeling? Is the patient going into sepsis, systemic infection, fever is there, count is increasing. If previously the count was normal, now it is increasing after 48 hours. What is the characteristic of sputum? What is the characteristic of secretions? It is there. Earlier it was clear sterile, now it is mucoid purulent. So based on that. And detection of the causative agent. Yes, the presence of the microorganism is very important to label any patient to be as ventilator-associated pneumonias. So that is what is the catch. First sample, it is sterile, and the second ET secretion sample, if it is coming up with a microorganism, you have to label it as ventilator-associated pneumonia. We further go into the details of pneumonia 1, pneumonia 2, pneumonia 3, that will jumble up the thing. I think in this talk, I would like to prefer mainly about the VAP, what are the surveillance, how it will take it, and what are the commonest organisms involved in it. Yes, it is the second most common healthcare associated infection, especially in the intensive care units, and the most common in mechanically ventilated patients. So what all are the microbes involved in ventilator-associated pneumonias? Yes, we have two sides. We have the early onset or the late onset. So for early onset, I think all of you might be, who all are working in microbiology labs in the laboratory side, they might be dealing up with this problem of early onset VAP, and especially this multi-drug resistant Klebsiella pneumoniae. Nowadays, it is a it is a nightmare not only for the physician, for the clinician, it is a nightmare for even for a microbiologist, because eventually, even with critical care cards, now that Vitec provides us with MIC's values, we have the change versions of this gram positive, gram negative, the non-fermenters. We have the critical care cards also, wherein we are dealing with MDR Klebsiella. We can go for the septus-irritative avibacterium. But the unfortunate part is we are having the resistance pattern for not only colistins and all carbaminomases. Now we are facing the septus-irritative avibacterium, this new molecule which came earlier, that is also resistant to this MDR Klebsiella. So it is definitely a nightmare for any clinician or for any microbiologist. Then we have E. coli, Enterobacter species, Serratia marcescens. Many a times methicillin sensitive Staph aureus and even MRSs are predominant. Streptococcus pneumoniae, they are also the reasons of early onset VAP, and Haemophilus influenza. Talking about the late ventilator-associated pneumonias, they are also typically MDR, and MRSA word defines it methicillin-resistant Staph aureus, multi-drug resistant Acinetobacter species, either it is Lofi or it is Acinetobacter baumannii, or the gram-negative non-fermenters. What we have, the Pseudomonas species related to Burkholderia specia, Burkholderia. So these are the commonest, again the multi-drug resistant bacteria leading to late ventilated associated pneumonia. So Pseudomonas, ESBS, they are the predominant. And not to forget here, yes, fungal causes are also there. So Candida, we have the new species with Candida, Candida albicans, Candida femata. These are the causes for late onset ventilator associated pneumonia. One word here I have to, when we talk about ventilator associated pneumonias, we have to talk about how do we score it. So basically, nowadays the endotracheal intubation, the scoring of that is required. So how we are labeling the bronchoalveolar lavage, how we are labeling the ventilator secretions, the endotracheal secretions, more than 10 to the power of 3 is considered as a significant for bronchoalveolar lavages, and more than 10 to the power of 5, that is 1 lakh colony forming unit, that is again significant for ET secretions to be labeled as significant VAP in our criteria. Then we have this clinical pulmonary infection score, CPIS score. I think so. There might be microbiologists sitting out here today. They might be knowing about this word, CPIS. So it is based upon this 5 parameters: temperature, how much it is. Based on that, we score it. So if it is beyond, just beyond normal, 0, 38.5, so beyond has 1, more than 39 degrees centigrade, it is 2. Then the leukocyte, the TLC count, whether it is in the normal range, whether it is less than the normal or more than the normal, we give it more. And more than 500 band cells, if are very much predominant in the peripheral blood smear, I think we'll go for this 2 scoring. Then comes the tracheal secretions. Either the secretions are there, none, so it relevance to 0. Mild or non-purulent might be taken as 1, and very thicky and purulent secretions are taken up as 2. Then, as I said, that the X-ray picture shows you a way things when the starting of the VAP is occurring. So there are no infiltrates, it is scored as 0. Patchy infiltrates are there, yes, it's 1, and it is a localized format, so the 2 scoring. Then the culture results, mild or no growth, yes, endotracheal aspirate. The CPIS score itself helps you out whether to label it the patient as VAP or not. So first sample was also negative. The second culture sample of endotracheal secretion, there is no growth, so there is a scoring of 0. Mild growth, as I said, that how do you classify as significant, and 10 to the power of 2 to 3 is also given as the mild growth, so 1. And moderate to high growth is there, so plenty of microorganisms are available, so that is labeled as 2. Then the oxygenation status, more than, it is labeling the absence of ARDS, and more than 250, yes, the component of ARDS is there. So based on this, we take up this CPIS scoring. And it accounts for we are looking for the clinical part, we are looking for the physiological, the microbiological, and the radiographical. So clinical is nothing but your TLC and the temperature component, physiological, your ARDS component, microbiological, the culture reports are feasible to you, and the radiographic picture, the X-ray infiltrates. So how much these 4 parameters are actually advising you, and what is the CPIA score that range from 0 to 12 and more than 6 if the score is there. So think about that, yes, your patient is going into ventilator associated pneumonias. Moving on to the surveillance of BAP. So how do we go for the surveillance of this? So when we talk about surveillance, definitely there has to be a numerator and a denominator. So number of ventilator associated pneumonias that particular month divided by the number of ventilated days in that particular month into 1000 is taken as the surveillance for BAP. This criteria, this thing is also taken up by your infection control nurse, day-to-day activities. As I first stated, what is the role of infection control team comprising of the infection control officer and the infection control nurse. Their day-to-day activities has to be jotted up by the infection control nurse. They have to take care of the bundle checklist. Daily, it has to be filled up, and then based on that, you will look up with the microbiological and your clinical correlations that which patient fits into ventilator associated pneumonias, and the number of days in that particular month for the particular patient is also added up. Moving on to the treatment, I think very quickly, if at all I can talk about, yes, late onset and the early onset, there are broad spectrum of antibiotics which are being used. So early onset VAP, second and third generation of cephalosporins. Earlier it used to say that yes, first and second generation cephalosporins can be used, but due to the predominance of MDR organisms, I think second and third generation cephalosporins, then fluoroquinolones, the newer fluoroquinolones, aminopenicillins plus beta-lactam inhibitors, and one combination of carbapenemases can be given. Treatment of late onset VAP, again, combination of cephalosporins, carbapenemases with beta-lactam inhibitors, plus one of the aminoglycosides can be a very good treatment for late onset VAP. Also for anti-pseudomonal, we have this fluoroquinolones. Apart from that, anti-pseudomonal ceftazidimide, that is third generation cephalosporin can be used. And plus for the coverage of MRSA, we have this vancomycin and denosumab. So how do we prevent? Infection control can act as a road roller on all these infections. This is a very beautiful picture once we had taken up from the sources. So how do we prevent it? It is a major work. As I said, that the team works with not only the nurse, the ground area where the nurses are working, where the healthcare staff, your ground staff is working. So you need to tell them, you need to make aware of them how to prevent this ventilator associated pneumonias. So this is a 5-element VAP bundle that should be followed in any hospital area, in any hospital practices. First and foremost, oral care with chlorhexidine. Yes, this picture depicts it all, that the 5 areas, the 5 predominant problems which a VAP patient, apart from dealing with ventilator associated pneumonia, can develop into some other infection also. So proper care of the oral area, hygiene of the oral area is mandatory, right? Cleaning with the chlorhexidine, teeth and the tongue area. So only the saliva cannot be the removal of all the bacteria from your oropharyngeal area. So oral care is very important in this ET intubated patients. Then lying in that position, stress ulcer prophylaxis, we need to have a clinician look out into that. Then daily sedation assessment and spontaneous breathing trial. A physiotherapy can help us in many ways in reducing the risk of ventilator associated pneumonia. So continuous pressuring at the back region, then physiotherapy exercises, breathing exercises. Nowadays with COVID, I think half of the world might be knowing about the spirometry exercises. So that will provide help to the person. Then deep venous thrombus prophylaxis. Patient is in the lying position, might lead to DVT, and another area where along with VAP, person might have another X disease with it. Head of the bed and elevator. Very commonly, at the bedside areas, nurses, they keep on doing it, but this 5 element of BAP bundle should be another checklist during your patient who is already endotracheal intubated, should be taken care of. So as I said that, only mechanical chewing hoegi, there is absence of saliva, and saliva itself cannot shed away all the bacteria. So the cleaning of that area is with chlorhexidine. That will reduce dental plaque or gingivitis, and it is a strong solution which is the strength of 0.12%. Hand washing. I think the world says about hand washing, and with this COVID area, we have learned many times, many areas, many ways. Hand washing is the single method for reducing any kind of transmission, is the key point to reduce any healthcare associated infection in our setup. And use of waterless antiseptic is nothing but use of hand rubs when you are moving from one patient to another patient. That is the 5 movements of hand hygiene is very, very important. So when we talk about BAP, the reduction of BAP can only be done by this 5 element BAP bundle, that is the oral care with chlorhexidine, stress ulcer prophylaxis, daily sedation assessment, DVT prophylaxis, and head end of the bed elevation. That are the 5 elements of BAP bundle, along with hand washing is the key point to reduce the ventilator associated pneumonias. Moving on, next we have the centerline associated bloodstream infections, CLEPSI. हम बात करते हैं CLEPSI की, but हम जब surveillance की बात करते हैं, the word changes into something else. Is it? Okay, there is one word named as CRBSI. So this is nothing but catheter related bloodstream infections. But when we are talking, we are saying CLEPSI. How is it different? See, the catheter related bloodstream infection, it is used basically for a microbiological, for the lab purpose, for the treatment purpose, right? But जब हम surveillance की बात करेंगे, we have to label it as centerline associated bloodstream infections. Isme bhi, if you go into detail of it, there are multiple things. Like the way I said about pneumonia 1, 2, and 3. So beyond learning all those points, simple BAP agar hum padh le to wo zyada behtar hoga. Same way, talking about only CRBSI and CLEPSI will be helpful for any hospital setup to understand what is the need and what is for the surveillance part. So CRBSI, when clinicians, they talk about, when microbiologists, you are labeling it. But as a microbiologist, when you are doing the surveillance part, it is the centerline associated bloodstream infections. How do you calculate it? Again, the thing has to be how many were the number of bloodstream infection, centerline associated bloodstream infection. Denominator has to be the total centerline associated days multiplied by 1000. So here the word about CRBSI, as I said that for clinicians it is important. We have this laboratory confirmed bloodstream infection, and the criteria here belongs to, first and the foremost, when you are sending urine sample up, immediately bhej rahe hain to before inserting, and after 48 hours, then you are labeling it as catheter associated. Same way when you're talking about ventilator associated pneumonia, so you're sending before intubation one sample, when you have intubated the first sample, and after 48 hours, we look for another growth and then we label the patient as ventilator associated. But when we talk about bloodstream infections, it has to be always paired. No single blood sample should be sent. It is always a paired blood sample which is supposed to be taken. So one or more blood cultures, as I'm saying, the organism has to be there, and at least one of the signs and symptoms of sepsis, that is either fever or hypotension, or which is not relating to that one culture, one microorganism should be prevalent. So that is laboratory confirmed bloodstream infections. What are the reasons? What are the basic risk factors for any centerline associated bloodstream infection to happen? It can be divided into 3 categories. That can be patient related, that can be device related, that can be, of course, a healthcare worker related. So when we talk about patient related, that is the age of the patient, mainly centerline bloodstream infections. It is documented nowadays. It is more in males. Any underlying disease is there, or the patient has lost his integrity of the skin and there is already a breach. So the multiple entry of the microorganisms can lead to a trouble for you. These are the patient related areas. Then we talk about the device related. This is important even in catheter associated UTI, even in the ventilator associated pneumonias. What is the type of there the catheter, how we are using, what is the composition, what is the flexibility, how much it may lead to, looking at the consistency only, whether it may lead to the biofilm production, what is the property of the device which you are inserting into the patient, the type of catheter, how many lumens are there, and what exactly is the site for how long you're putting it, and what was the indication. What was it, an elective or it is an emergency? What was the indication for you to put the device in a particular patient, in a high risk patient? So these are the device related risk which we generally see. Then we move on to the healthcare worker related. That has to be either it is an untrained person, or there is a breach in the practices, how you are inserting the catheter. So again, it is healthcare worker related only. Or the healthcare worker is not trained. Maybe it's a trainee, maybe it's a fresher. So you are not actually dealing with the right person who knows how to insert a central line, how you can help out. So you have immunocompromised patients, you have how to identify which catheter and what are the risks which can lead to central line associated, the catheter composition, and then we have the healthcare worker related challenges which may lead to central line associated bloodstream infections. Moving on, what are the typical clinical etiological agents which may lead to central line associated bloodstream infections? The most predominant one, it can be a gram-negative bacteria from the Enterobacteriaceae family. Most commonly, we have MRSA, again a nightmare to any clinician and to a microbiologist. In Staphylococcus aureus also, these days, methicillin-resistant Staph aureus is very, very predominant. So if I can say about Enterobacteriaceae family, Klebsiella pneumoniae, MDR Klebsiella pneumoniae, and Acinetobacter multidrug resistant. And in gram-negative, if we have MRSA, that is the deadliest experience for any clinician or microbiologist to happen. So the various etiological agents which causes central line associated bloodstream infections are Staph aureus, Pseudomonas aeruginosa, E. coli Klebsiella, Burkholderia cepacia, Cynotrophomonas maltophilia. Then we have fungal reasons also like Candida, Enterococcus, Serratia, and very rarely Coagulase negative Staphylococcus. Now here I have to emphasize about Coagulase negative Staphylococcus. When we talk about, there are studies, there are journals which says that it's a paired blood, right? Then is it, since a patient related risk breaching in the skin integrity, if it already the skin integrity is there, yes, it might be a commensal from the skin. So is it because of that we are having this coagulase negative Staphylococcus, or we actually have a pathogenic Staphylococcus epidermidis, mainly in cardiac patients, mainly in valvular replacements? That is quite helpful to identify whether it is a pathogenic, whether it is just a skin breach and it can be taken up as a normal flow. Pathogenesis, I think if it's a foreign body, there is already a foreign body placed out there. So that the number of lumens, as I said, how many lumens are there? If microbial adherence is there, that may result into biofilm colonization and then the biofilm formation, leading to all the sepsis parameters. So how do you diagnose catheter-related bloodstream infections? Only blood, as I said, that there has to be a paired blood culture. No single blood culture is taken up. And especially there are areas, there are hospitals where this practice is still followed, that tip culture from the catheter, whichever is placed in the bloodstream, the tip cultures are generally taken. It is not taken up. It is completely banned nowadays. Nobody goes for this tip cultures. Same goes with if anybody from your clinical side, they are sending you the catheter tips from urine catheter tips, endotracheal secretion, endotracheal tube secretion tips. You should completely say that no. As a microbiologist, you should strictly say that it is not advisable, it is not practicable these days. Catheter tips of any areas are not taken up. Okay, when we talk about this blood cultures, I think as a microbiologist, I need to emphasize about the semi-quantitative cultures. We need to know about this. And nowadays, the word about differential time to positivity, you need to know this. So when you are collecting, what is the collection time? How frequently, how fast you are sending it to the microbiology lab? After sending it to microbiology lab, was it immediately pushed into the bactec instrument? After pushing it into the back duct, when you place it into the back duct, when the signal was given positive, when it has flagged positive, and after flagging, when you have subcultured it and finally put it on to Vitec antimicrobial susceptibility. So when the organism was identified, what is the anti-susceptibility reporting pattern? So transport time, the time to positivity. So differential time to positivity includes, this whole thing is nothing but this whole thing is the time of reporting from collection of the sample to the final identification and antimicrobial susceptibility testing. That completing is nothing but the time of reporting. But talking about differential, आपने जब sample लिया तब तक positive आया. From the time of entry into the backpack to the time of reporting, that, and from the time when we have taken the sample, that differential time has to be calculated and finally given it to you. So clinician is much more concerned. I have sent the sample today, at what time it was placed, and immediately after placing, what time it came positive. So it is within a very short span of time, or it has taken 24 hours or beyond that. So that differential time to positivity is relevant nowadays for the clinicians to know about what can be the likely reason. So because as I said that there can be pre-analytical errors at the time when you're collecting the sample, there can be analytic when whether the bottle was placed immediately or it has taken a number of hours to push the bottle into backpack. Okay, there are certain guidelines when we talk about the strategies of how to reduce. One second, sorry. How to reduce this Centerline associated bloodstream infections. First and the foremost, these red areas, what I can show you, the plus ones, you cannot hide away, you cannot run away from these challenges which are occurring into our day-to-day activities, and we really predominantly have to look into these areas. So we need to have a checklist, we need to have a bundle checklist, we need to have the areas where the breach can occur. So quality assurance and continuing education, I think every weekly, daily activities are definitely entertained, but every weekly training of the healthcare workers, especially the nurses, it is important, so that the quality assurance is kept in place, so that they are aware whatever the practice is. There might be some days are there when there are entries of the new staff, when there are entries of the new ground level staff, GDA staff. So for them, how do you look for the quality? So training is there, and apart from the training, the assessment is also very, very important. We need to know what kind of practices they are following and whether what they are following are correct or not. So we need to have a regular assessment of our healthcare staff so that they are aware of the recent or the newer challenges what they are facing. So continuous education is required for a healthcare staff, that is with the help of infection control team and the quality area. They can provide us help in providing us continuous education to our healthcare workers. Then which site, as I said that key risk areas include, along with patient, along with healthcare worker, we need to have the device related problem also. So a subclavian site is preferred instead over a jugular or a femoral site. Then hand hygiene, कंटिन्यूस एजुकेट करेंगे तो हमको हैंड हाइजीन के बारे में आप रेगुलरली एम्फसाइज कर पाएंगे. Barrier precautions, whether you have used the gloves, proper antiseptic procedural things were happened or not, sponges were available for CVC insertion. Then changing administration sets at appropriate intervals. So whenever you are bandaging, whenever you are putting up the dressing, whether the dressing is clean. ये नहीं कि आपने एक बारी Centerline डाल के you have just left it for 2 days or more than 24 hours. Nobody has checked for it. And whenever any healthcare worker is checking for it, I hope they are not doing it with their plain hands. They're putting on the gloves, and beyond putting on the gloves also, are they doing the 5 movements of hand hygiene when they are manipulating any of the interventions. Then how frequently the removal of catheters, it is indicated, and antiseptics are being used or not. What is the type of dressing, that is also very important nowadays. Not a plastic, it has to be a transparent semi-permeable polyurethane dressings which should be used, not that the previous old gauze pieces you're piling up and just putting up the white plaster, then that cannot be taken up for Centerline anymore. So these are the basic practices. This is one of the beautiful pictures. how the centerline is inserted, and the areas has to be cleaned, how they are looped up and how they are correctively tied up. This is one of the centerline bundle checklist we have. I can just show you. So along with the name, what is the diagnosis, the type of centerline you're putting up, the IDs, the hospital IDs, when it is inserted, if it is a removal, when it is removed on. So at the time of an insertion, these are the basic things. The basic things any healthcare staff needs to know and have to have a checklist on this, that whether who was, because one who is performing, the other one can just stand and check out whether all these checklist was maintained or not. So hand hygiene was done or not, barrier precautions लिए गए कि नहीं लिए गए, अगर लिए गए, well and good, yes, you can put up. If no, what was the reason? Was there any emergency that some breach in the practices was done? Skin antisepsis, which disinfection you have used, dressing, what is the type of dressing it is done, who has inserted it. This is very important. This is very common in our hospital setups. The blame game keeps on going on that yes, he has done it, she has done it. So at least you have a name, you can identify, and you can at least train that person, and further this kind of problem should not arise. What is the designation? Is it a trainee or it is a trained healthcare staff? What is the site? And if it's not a subclavian, what was the reason for putting up the femoral site? And these are the centerline days. This is based on 1 to 30. I mean, so on the list goes on. So daily centerline days you need to count for how many days it is picked up. That is how a patient is labeled, the denominator, this patient, and if there are other patients also, इसी तरह से हम लोग denominator calculate करते हैं. Moving on, next we have the surgical side. So till now we have spoken about catheter associated urinary tract infections. We have spoken about ventilator associated pneumonias. We have spoken about centerline associated bloodstream infections. Fourthly, we have the surgical site infections. This is a very tricky one and a very favorite of mine. Why? Because many a times this is misdiagnosed, overdiagnosed, and at times not even diagnosed. I think 90% of the microbiologists, they face challenge in picking up this surveillance surgical site infections. Talking about surgical site infections, broadly we classify it as incisional and organ space. Or incisional is further divided into superficial and deep incisional surgical site infections. Okay, talking about the superficial, नाम से ही आप समझ आए होंगे कि superficial है. Superficial है. So there is no funda of 24 or 48 hours anymore. So that was compiling up to centerline associated, catheter associated UTI or BAP. When we talk about surgical site, it has to be days. So superficial is anything, any infection after the surgery of within 30 days, and it involves not only skin or subcutaneous tissue of the incision. And one of the findings which is some serous or purulent discharges there, with or without confirmation from the superficial incision. Pain or tenderness has to be there. So these are the brief areas jahan pe aapko we have to look for it. So any person who's coming after 30 days of surgery to a surgeon saying that I have some purulent discharge from my stitch line, there is some discharge which is oozing out, and it is beyond almost a month that this is oozing out. There is pain, there is tenderness, and there is swelling. So that is nothing but the superficial incisional surgical site infection. Okay, what is not to be reported as surgical site? Stitch abscess with minimal inflammation, just redness हुआ है, एक हल्का सा indurated point लग रहा है आपको, right? Then infection of an episiotomy or newborn circumcision site, that is not considered as a surgical site infection. Thirdly, infected burn wound is also not considered as a surgical site infection. कई बारी misdiagnosed हो जाता है. Person is coming with just a stitch abscess only. Can we consider it as? No. First of all, the days. First, secondly, look for what are the actual signs of inflammation or swelling are there or not. If it's not there, you don't have to bother about it. Right? That is about the superficial. When we talk about deep incisional, so deep, again, the word is defining. So any infection which is occurring within 30 to 90 days, and beyond 90 days, no. Before 90 days, after the surgery, and it is involving the soft tissues. That can be any muscle, and at the point of incision you can look for. And the culture has to be positive, along with any of the signs of, again, inflammation. There is drain, there is discharge of the organ space, and any signs and symptoms of swelling, pain, tenderness is available. So that is deep incisional. So superficial is nothing beyond 30 days, and deep incisional is nothing beyond 90 days. So these are the two types of surgical site infections. So here comes the glitch. When we talk about what are the risk factors after surgery, yes, the person who is diabetic, very likely to have that he or she may land up into SSI, a superficial or a deep one. Multiple use of steroids, malnourished, all the immunocompromised components can lead up to prolonged hospital stay. Apart from that, there is no movement of the person at one point of time, no proper care is being taken, that can lead to. So surgical site infection, first and foremost, it's not that only in the hospital setup only patient is getting it. Yes, he or she might go back home after 30 days at the point of incision if there is any drain, if any swelling, if any pain, any tenderness, and that discharge is showing any positive sign, with or without positive sign, that can be lead to superficial. And agar koi space involved hai, koi muscle involved hai, with the culture positive, with pain, with tenderness, with discharge, can be labeled up into deep incision. So what are the commonest organisms? As I said that this MRSA is again clinician's challenge. So it's a beautiful picture showing some MRSA hospital. We have a MRSA ward, we have MRSA clinic, we have MRSA specialist unit, we have department of MRSA, we have MRSA-ology. So you name it, I think the hospital is having the criteria fitted up for MRSA. So methicillin-resistant Staph aureus is the predominant surgical site infection organism which is prevalent. The Enterococcus in another gram-positive. Talking about gram-negatives, we have Escherichia coli, we have Pseudomonas aeruginosa, Enterobacter, Proteus mirabilis, Klebsiella pneumoniae, Streptococcus again a non-enterococci, and some of the anaerobes are also predominant in causing surgical site infections like Bacteroides fragilis. Okay, this was all about the surgical site infections, right? And talking about the universal precautions, we have this hand hygiene, use of personal protective equipment, safe injection practices, and environmental and medical equipment cleaning. This all will be dealt by another colleague of mine in the coming up lectures. Briefly, I think as a microbiologist, as a member secretary of the infection control at my hospital, at my institution, I will talk about hand hygiene. I think those who are working in the hospital setup, they might be aware of this 5 moments of hand hygiene. So all the healthcare staff, this is what is the assessment and the continuous education talks about. In a healthcare setup, we need to assure that our ground staff, that our healthcare staff, they are very much aware of this hand hygiene. What are the steps of hand hygiene? What are the 5 moments of hand hygiene? So whenever I ask, I think कई बारी staff, नए trainees जो आते हैं, ma'am, before and after touching the patient, that is the only time we require hand. Sorry, it is not like that. The 5 moments of hand hygiene are clearly demarcated by WHO. It is firstly when you are touching the patient, then after coming in contact with blood or any other body secretions of the patient, at that point of time you are supposed to use a hand rub. Then prior to performing any aseptic task or you're manipulating any of the areas of the patient or any body fluid exposure agar ho raha hai, so us pe aapko definitely you need to have a hand rub. And after touching the patient, I think there are queries when people talk about that ye 4 areas to ho gaya. Why after touching the whole, when you have touched before and after the patient, why after touching the patient surrounding? The answer to this is after touching the patient, yes, you have channelized, you have used the hand rub. But beyond that, if you are going to the next patient, before that, if you have touched any of the raw surfaces like the bed handle, like the bed head end, the bed end, the foot end, you have touched it. So for that point, we are very much likely to use about for hand rub after touching the whole environment of the surrounding of the patient. So these are the 5 moments of hand hygiene. I think the photographs in any of the NABH standardized hospital, it might be available. This has to be followed. Talking about the important part, so I think as infection control team, you also might be facing challenges whenever you ask your healthcare staff, especially to the newer people. Even many clinicians, if at all you ask them how many steps of hand hygiene are there, they look at the charts and they say that I think there are 10, I think there are 11. So we need to train them efficiently, saying that the opening and closing of the tap and using of a towel, they are not the steps of hand hygiene. So very quickly, I think here I would like to add up the video. If all of you can join me along with your videos, that would be great. Is everyone there? If people can join me along with the video. Okay, very quickly, as a microbiologist, so this is my job. I think I would ask everybody, all of us, we can do the 6 steps of hand washing. So first one is applying the leather. Opening and closing of the tap is not the steps of hand hygiene. Please mark it, and even to your clinicians also you can say that definitely these are not the steps of hand washing. So first is forming the leather. I don't have water and hand wash out here. So first is rubbing, apply soap and rub palms together to ensure the complete coverage. So your first and the foremost point is you're forming the leather, right? Then second point is spreading the leather over the palmar surface or the dorsum surface of the other. So this is your second step, right? Third one is your interdigital spaces, right? This is your third step. Fourth one is this fingertips. You are just forming a knuckle, and this is how you're cleaning for the fourth step. So you remember it like this: 4 and forming a fist. This is nothing but your fourth step. You're cleaning the tips of your fingers, right? Fifth one is your anatomical snuff box area. So this is when you do a normal hand wash, a simple one also. So this area is always left out. That is why this fifth step is important, because this anatomical snuff box area should be covered well and it should be cleared well. That is why the fifth step of hand washing was introduced. Last but not the least, forming a fist over the palmar surface of the other. This is your sixth step. So if you can, all of you, you can follow along with that at your places. So first one is forming leather. Second one, spreading the leather over the first and the other hand. Third one is interdigital. Fourth one is you're combining and you're making a fist. This is your fourth one, right? Fifth one is your anatomical snuff box area, right? And sixth one is making a fist and rolling it over the palmar surface of the other hand. So these are the 6 steps of hand washing. Opening and closing of the tap is not the steps of hand hygiene. They are not the steps of hand hygiene, right? Okay, very quickly. ये मेरा favorite photograph है. Why? Because from the time I started, and I remember when my teachers, they formulated at my institutions, the hospital infection control committee, they always said that हमें भी यही सुनाया जाता था, आगे बेटा आपको भी यही सुनना है. So what? This picture is a beautiful picture who says that when a microbiologist is saying that please go for hand washing, please ask your staff to go for hand washing. तो क्या बड़ी बात है, हाथ धोना ही तो सिखा रहे हैं. But I'm sorry to say that, sir, हाथ धोना आज की डेट में, I think अब तो कोविड ने भी बता दिया है, हाथ धोना is the basic requirement for the prevention of this infection control. Right? Despite the advances in hospital infection control, translating similar-based theory into practice is still a challenge, and I completely agree to it. Yes, हाथ धोना ही तो सिखा रहे हैं, but अभी भी आप लोगों को हाथ धोना ही तो नहीं आ रहा. If you are following it, if you are following the practices, you are helping the infection control team to, in the day-to-day activities, that we don't have to keep on emphasizing that please go for hand washing, right? So this was all about my talk.
Now we are starting our second session in this hospital infection control webinar. To discuss with you, we have with us Dr. Suchitra Jain. She is Senior Consultant Microbiologist in the Department of Laboratory Medicine at Max Super Specialty Hospital, Patparganj. And she is working there since April 2010. And in addition, she has some other responsibility, like she is Infection Control Officer in Max Super Specialty Hospital, Patparganj, Noida, and Greater Noida. She has done her MBBS and MD from Jawaharlal Nehru Medical College, Aligarh. And she has also worked as faculty in the Sri Aurobindo Institute of Medical Sciences as Associate Professor, Indore. She has also done Masters in Hospital Management from National Institute of Health and Family Welfare. She has certification of infection control by Asia Pacific Infection Control Society, Singapore, and she is also trained in ISO 15189 as internal auditor in 2012 and again in 2014, and she is also assessor with NABL. So she has vast experience related to quality. She has vast experience related to infection control. She has vast experience because she is working in Max Super Specialty Hospital, one of the top institute of India. Implementation of this quality requirement and infection control requirement in a hospital setup. So all of you will be benefited by her vast knowledge. So now I will request Dr. Suchitra Jain to start with her presentation.
Thank you, sir. Thank you so much for such a warm welcome and giving me an opportunity to for this hospital infection control workshop. Okay, so sir has given such a warm welcome, and most of the things Upasana has already covered. What is hospital infection control program? Who are the members? What are the important things as in hospital acquired infections? What are the markers? She has already covered. My topic in these 2 hours will be about personal protective equipments, needle stick injuries, the outbreak management, and cleaning and disinfection protocol. So we'll start our presentation with personal protective equipments. So personal protective equipment simply means that what are the things you should, Personal protective equipment, it's a specialized clothing or equipment worn by employee for protection against infectious material. It prevents contact with an infectious agent or body fluid that may contain an infectious agent by creating a barrier between the potential infectious material and healthcare workers. The types of protective healthcare setting equipments we wear in a healthcare settings are gloves, protect hands, gowns and aprons, usually they protect skin or clothing, mask and respirators protect mouth and nose, respirators protect respiratory tract from airborne infectious agents, goggles protects eyes, and face shields protect face, mouth, nose, and eyes. So after the event of COVID, I think we all understand what are personal protective equipments. Now goggles, they surround the eye area. They give more protection in situations where you might encounter splashing liquids, fumes, vapors, powders, dust, mist, and they indicate that they are chemical splash goggles to be worn for that purpose. But the limitation usually here is that the fogging occurs whenever we are wearing a mask, as we have experienced, so many of us must have experienced this, that fogging occurs, and that is why the goggles are usually sometimes difficult to wear. The gloves, the purpose is where both the patient care, environmental surfaces, and other. The glove material which we use is vinyl, latex, nitrile, and other materials now available like spandex and all. Sterile, they can be of 2 varieties. One could be sterile, the other can be non-sterile. Okay, sorry about that. So good afternoon all. I hope you had a good tea break. And personal protective equipments we are talking about. So it's a specialized clothing or equipment worn by employee for protection against infectious material. Ppe prevents contact with infectious agent or body fluids that may contain infectious agent by creating a barrier between potential infectious material and healthcare worker. So types of clothing we have in healthcare settings are gloves, protect hands, gowns, aprons. They protect skin or clothing. Mask and respirators, they protect mouth and nose. Respirators, they protect respiratory tract from airborne, especially infectious agent. We must have seen in this COVID, there are a lot of people, those who were wearing respirators. Then goggles protect eyes, and face shield protect face, mouth, nose, and eyes. The goggles, they surround the eye area. They give more protection in situations where you might encounter splashing liquids, fumes, vapors, powders, dust, mists. They may indicate that they are chemical splash. Goggles to be worn for that purpose. But when we wear goggles, the limitations is usually the fogging. The gloves, they protect patient care, environmental surfaces, other things. Glove material, vinyl, latex, nitrile we can use. Sterile or non-sterile, there are two varieties. One pair or two pair we can use, single or reusable. Now reusable gloves usually we don't recommend because of the infectious waste they might be carrying, which might not be able to wash off in various procedures which you do when we have to autoclave it, or if the autoclave is not working correctly, then there are a lot of limitations if we use a reusable, and this is not recommended now. Usually the gloves, the do's and don'ts of glove is that you have to work from clean to dirty. That means the area which is clean has to then go for the dirty area. But the limited opportunities are for touch contamination, that you have to protect yourselves, others, and the environment. So whenever what we have seen is usually when you are wearing a gloves, you become a little bit relaxed and you keep touching the other surfaces. So you should never touch your face or edges PPE with contaminated gloves. Do not touch environmental surfaces except the area necessary wear during the patient care. This is the most important recommendations which we do. The masks, they usually protect nose and mouth, but what we have seen, and there were a lot of memes coming up that people, how they are wearing masks. So there were usually full training need to be given that mask should fully cover nose and mouth and should always prevent fluid penetration. There are different type of masks which we have learned in this COVID era. There's a 3-ply mask, then there is respirators, but the most important thing required during this is a fit test. Fit test means that you have to blow inside a mask to see that no air escapes from the mask, and that is what a fit test is there. There are 3-ply masks. They can be used in non-critical areas, and when you are going in shopping or malls and all, which may be of cloth mask or maybe of other varieties. But respirators, especially N95, which we have actually seen, they are need to be used when any splashing procedures needs to be done, like intubations or any procedure which has to be done on a positive or a suspected positive patients. Then we should be using these masks. Then there's always a sequence of using a PPE. So that is usually recommended by CDC, that what should wear should also be, and this is usually why, because that in that way we will be able to protect ourselves whenever we are in a contact of a patient who may be COVID positive or any infectious patients which we have to use. So sequence of putting on the personal protective equipment is gown, and mask, respirators, goggles, face shield, and gloves. So how to wear a mask? There's a way how to wear. There's usually a pile where the mask, your gowns are there. So you have to select your appropriate size. Sometimes what happens, you end up wearing a larger one and you're not able to protect yourself, or you may wear a smaller one, which again will not protect. So select an appropriate type and size. Usually there's an opening in the back which need to be secured. You can secure it yourself, or somebody from your team can secure. Or if the gown is small, if it is too small, you can have 2 gowns, one you tie in front and one ties back. We have seen that a lot of PPEs were not available usually in the first wave. So the appropriate size was a problem in that era. What we did, we used to take up 2 gowns instead of 1 if the appropriate size was not available. Then how to wear your mask? Usually place over nose, mouth, and chin. fit flexible nose piece over the nose bridge. So you have certain oil pins and something which a pin is there, which needs to be pinned whenever you are wearing that mask, and then you have to secure it with head with ties or elastic and adjust to fit. So this is the most important thing, that fit test needs to be done. Otherwise, what happens, the air can enter from the sides if it is too loose, or if it is too tight, then you won't be able to breathe properly. So adjust to fit is the most important step whenever you are having a mask. Then you have to position your goggles over eyes and secure to the head using the earpieces or hand. So once you wear a gown, then you wear your mask and then adjust your headbands accordingly, so that, and you should see that whenever you're breathing, that fogging does not occur in that case. So that is the important step. Then you have to don your gloves lastly. So what you do is select an appropriate type and size. So you should know that there are various sizes available in gloves. It may be 5, 6, 7, 8, whatever your number is. Usually 5 or 6, they are fits into girls, and 7 and 8, they are usually for boys. So you should know what is your glove size. Otherwise, whenever you are manipulating any material with the gloves, you won't be able to manipulate. So the purpose is that it should fit tightly over your fingers, and it should always be taken it in account that correct type and size is there. So you insert hands into gloves. What you do is usually make a balloon out of it and then try to insert from one by one finger. And after you wear the first glove, then you extend gloves over. After wearing both the gloves, you can extend your gloves over isolation gown gloves. That is the right way of wearing a gloves. So this is how you should be. So this is a picture which we have shared, that first the gown is there. You can see the gown, it needs to be secured. Then mask and respirators, they are taken into account. This is what the picture says, that you have to blow into the mouth to test your fit test. And then the face shields, in these 3 steps, the face shields are being adjusted, and the gloves then has to be extended. So this is a work practice you should always done. When we have started with our COVID ward, the donning area was usually a different area, where usually 2 people were there to make you help in donning this gloves. So this process, the whole process of wearing the sequence of this is known as donning, and this became quite famous when the COVID areas were there. So what we had done is, when the COVID wards were identified or critical areas were identified, there has to be a different donning area where people would don together or singly, whatever the shift may be. So this was the most important sequence, and a lot of trainings need to be done during this donning procedure. Why? What is the importance of having this donning technique? The important technique, as I told, was that it should not touch the surfaces again, which are clean. Okay, so this is the donning, which is most important thing, which we had always trained. And when personal protective equipments, they are taken into account, we should be taking care of this. Then comes the other part, that is how to remove personal protective equipments. The personal protective equipments, they are called as doffing, and this also has an important procedure how to doff. So the most important thing here is that contaminated or outside front, they are the areas of personal protective equipments that are likely to have been in contact with body sites, materials, or environmental surfaces where infectious organism may reside. And this is what it is important. This simply means that areas that are likely to be contacted, like body sites, if you are having a pus dressing or you are inserting a Foley's catheter, that is where you should be protected. The environmental surfaces, usually it is said that in a patient area, the 3 meter till the 3 meter areas, the infectious organism of that particular patient resides. So the ideal distance between the 2 beds is by all guidelines is given as 3 meters, because that is the area where the distance between the 2 beds is. And we say that there are 2 kinds of flora in that. One is called as transient flora, the other one is called as resident flora. So 3 meters usually have the transient flora. That means if the patient is infectious with some notifiable diseases of some infectious disease, say COVID-19, or it could be any other disease like chickenpox, it could be any other disease, measles. So there are different tuberculosis. All these surfaces, whenever we come into contact of that within 3 meters, the patient area will have that kind of flora. My flora is different from patient flora, or the other flora, that is bacterial flora. And when I talk about flora, it simply means that bacterial flora is different in each of us as a individual. So my flora is different from the patient flora. That we need to understand. And that is why the stress is that whatever the body sites and material we come across, it should always be taken into account whenever we are wearing a PPE. And environmental surfaces where the infectious organisms may reside. The other important point is clean. It should be inside, outside, back. That means it should always be back fold, ties on hand and back. Areas of PP that are not likely to be contaminated with the infectious organism. So clean area, jo hum pehne bhi hote hain, like we are wearing your gloves, the inside is clean, but outside is contaminated. Same way, the gown in front, it is clean, and in front it is contaminated, and if we open inside, that will be the clean area. That is what it is. It simply means areas that are not likely to have been in contact with the infectious organism. So I hope this is clear that contaminated and clean areas of PPEs needs to be defined, and that needs to be taken into account whenever we are doffing our egg. So sequence of removing PPEs, the most contaminated thing, the things which wear last, it needs to be taken out first. So gloves, we wore it last. So we will take out gloves in that case, and then the gown will be taken because that will be more contaminated than face shields and the mask and respirators. This is how we usually have. So in COVID, there was a practice that we were wearing 2 kinds of gloves. So gloves, which is the outermost, needs to be removed first. So how do you remove gloves? You grasp outside the edge near the wrist only. You don't touch the fingers. Okay, so what we have to do is we have to wear from the wristband, we have to grasp outside edge near wrist, peel away from hand, turning glove inside out and hold it in the opposite. So you will take out that gloves in that hand and then hold in the opposite gloved hand. That means you will not contaminate, you will not touch the surface of the contaminated gloves anytime. Okay, and so this is how you do it. Grabs outside near the wrist, peel away from hand, turning gloves inside and hold it on opposite to the gloved hand. Then what you do is then slide. Now you see in this picture that this is the contaminated gloves which is there. You see it, and from the other end, slide the ungloved finger under the wrist of the remaining glove and peel off in such a way that it will create a bag of the contaminated glove which has been taken out, and it will go inside the other glove. That's the most righteous way of removing gloves. Okay, so this is the most important step when we are whenever we are doffing, because usually the donning will never create any contamination. Doffing simply means that you have been in the contact of your patient, and all the touch surfaces, the high points, they are the most contaminated points. They have been touched by the gloves. So gloves are said to be the most contaminated thing whenever you are doffing. And if you are not careful in doffing the gloves, it will contaminate the other materials around. So this is the most important step. I would suggest that whenever you are removing gloves, you should always be taking care that the other gloves goes inside the first gloves, or at least it should not be contaminating the other areas. So take out the gloves, and as soon as you take out the gloves, you should be throwing in the red bin. okay, by biomedical waste management. But in case of COVID, we were throwing everything in the yellow because these were the guidelines which have come that everything consistent of COVID will go in yellow waste. Otherwise, the gloves usually goes in the red bin. Then the other part is removing gown. Now, how you have to remove the gown? You have fastened the ties backside, so you can peel away the unfasten the ties, then peel gown away from this. So you have to take out the upper portion of your gown and take it from the neck, then take it from the shoulder. And while doing so, you should try to roll the inside surface. As I told you in the first few slides, that outside is contaminated, inside is clean. So whenever we are trying to peel away any gown, then the inside is clean. So their aerosol production or the airborne infectious organisms does not spread on the larger area. So we keep on rolling our gown in such a way that the contaminated remain inside. So turn contaminated outside towards the inside. Now fold a roll into bundle and again discard into the yellow. So this is how the removing gown takes. Now what you have to do is grasp ear or head pieces with ungloved hands, lift away from face and place in the designated respectable for reprocessing. But usually we were not throwing our goggles or face shield. At least face shield we was throwing if there was a lot of availability. It all depends on the resources which were available to us. We used to decontaminate after grasping this ear and hand pieces with ungloved hand by ungloved hands, because that is now we have clean hands. And after usually taking away the gloves, we should always perform an hand hygiene every time also. So lift away from face, don't try to put it over the nose, and place it in a designated receptacle. We used to have different markers, or we can always put a marker over our goggles, write our name and disinfect it with 70% alcohol. This is what we were doing. Even the face shields were sometimes when it was we were not able to procure more face shield, those face shields were also cleaned with 70% alcohol rub, and they can be then used it for the further reprocessing, or according to the need it could be disposed again in the waste material. Last to remove is a mask. Why? Because as I said, there's lot of aerosol production, lot of airborne infectious waste whenever we are doffing. And that is why we have to, whenever we are removing a mask, we have to untie from the bottom, then top and tie, and remove from the face and discard. So there was the 3-ply masks, they were available on a large basis, so we were discarding. N95 masks, they were the resources were not so much. So only in critical areas where we were having COVID positive patients, we used to discard N95 masks in our hospital setup. Otherwise, AIIMS have taken out a policy in which you can have, what they were doing were, they were giving 4 masks for each person for a month. Okay, so every week you have to use a mask. And what they were doing were, either they were putting up, whenever you use an N95, you don't have to discard it. What you have to do is, in that case, first you put it in a sunlight for 3 days. You wear the other mask. Okay, the second day you will take out the second mask, and you will again take it, put it in sunlight. After 3 days, on the 4th day, your N95 mask was again, due to sunlight, it has got UV rays, which usually kills most of the microorganism. It could also kill the various viruses. So those were sun-dried masks, and then you can use it on a 4th day. So N95 also reusable. Some of the techniques what they were saying is that they can also, they were fogging their material, but fogging, when N95 was done, it was shown that the fibers inside that N95, they were being clogged and it was of no use. So fogging and fumigation were discarded for most of the things. Otherwise, sunlight in which they would put it in a brown mask, it was ready to use. So it is not always necessary that you had to remove, you had to throw your mask. You could also use your N95 for some period of time, and the time period usually was given 4 weeks. Okay, so every week, and in our case, what we were doing was that we were changing masks after 3 to 4 days. In critical areas, we were changing our masks. So it all depends what is the policy, what are the resources available at your place, and what are the things according to your departmental use you can have masks. So in our areas, we have also defined the mask in that case, that critical areas will have N95 mask. In case of non-critical areas, we were using 3-ply masks, like from engineering, housekeeping, support, they were using the 3-ply mask. Sometimes 2 double masking were also being done. So it all depends what is the policy. But the thing is that if you're coming in contact with a known infectious patients, you should be always wearing in a proper manner. That is what required. And after you doff, you have to perform hand hygiene immediately after removing. In case of actually, in case of donning and doffing, after each steps, you should be performing hand hygiene. And if hand becomes visibly contaminated during PP removal, wash hands before continuing to remove PP. This is what it is written. But what we recommended was that in between the steps of wearing your from your gloves to gown to mask and to respirators, all the steps will have hand hygiene in between. And during doffing also, we have to use in between all the steps, like we were removing your gloves, then your gown, again your goggles or your face shield, and your again the mask. So all the time you were using hand hygiene with hand rub, which is already told by Upasana that it consists of 7 steps, and it has to be done between 20 to 30 seconds. That is what is recommended from WHO guidelines also. It takes just 20 to 30 seconds. And after you have doffed fully, then you have to wash your hands with soap and water or using an alcohol-based hand rub. This is what is the recommendation given for your doffing purpose. I hope this is clear, and this is how we do our personal protective equipments. Order of wearing, I have already told, removing, and this is what. So another topic of infection control workshop is, these are the untouched topics. Usually I would say most of the time it is not covered in most of the infection control workshops, and but this is the most important point. And believe it or not, in my HIC, most of the things, it will be like we would be having a lot of say in meetings that cleaning and disinfection protocols needs to be strengthened all the time. The simple answer for this is that maximum load, bacterial load, a patient comes and stays in the hospital at least 2 to 3 days. Okay, and the hospital, the environment will become contaminated by that patient's bacterial flora or viral flora, whatever flora we can call it, or the microorganism, in simple term we call it. Okay, so if we don't clean it, our environment, that bacterial load will keep on piling up in that particular. So we had a policy of we as at Max Healthcare, I say, that have a very strong policy for cleaning and disinfection protocol. So I hope the screen is visible to everybody. So the purpose here is to ensure the proper evidence-based practices of cleaning and disinfection for patient care equipments in area. So whenever we make a policy of cleaning and disinfection, the classification of this is that patient care equipment should be there. Whenever we are trying to make a policy of cleaning and disinfection, we try in 3 ways. One is that what are the equipments that are used in patient area, okay, And according to the equipments, we would classify the cleaning and disinfection protocol. Then what is the method for each cleaning and disinfection protocols? They will be important. And then the cleaning of patient areas. So whenever we are having cleaning and disinfection policies made, these are the three important points which we should remember, that what is the patient care equipments. So it could be critical, non-critical. So there's a Spalding classification, we call it Spalding classification. That is what we say it, where it is divided into non-critical and semi-critical and critical equipments. Non-critical equipments are those which goes on the skin surfaces only. Semi-critical equipments are those equipments which will tongue the mucous surfaces, and critical equipments will be if it goes inside the patient mucous beyond in the spaces, in the sterile spaces. Okay, so that is known as Spalding classification, and according to the equipments, we would use it. Like for non-critical equipments, we would usually use a alcohol drop, and in case of semi-critical equipments, we would either use. I can see somebody. There's no problem with slideshow. Somebody saying slides are not moving. Somebody is saying that slides are moving. So I'm on the one single slide only right now. So I'm not moving any slide. I'm just trying to explain the patient care equipments here in this slide. Okay, so patient care equipments, I was telling, semi-critical, non-critical, semi-critical, and critical. So in case of semi-critical equipments, we would be using something like endoscopes and bronchoscope, we say it. We use usually high-level disinfectants, like 2% glutathione solutions are needed in that case. In case of critical equipments, we would try to make autoclave all the equipments if they are heat, not heat labile, they are heat sensitive. Okay, in case of methods, this is about the classification of patient care equipments, and that is what we need when we talk about cleaning and disinfection. When we come to methods of cleaning and disinfection equipments, I've already told in case of non-critical, we would be using 70% alcohol rub, like thermometers we need to clean, or any spatula we need to clean, which is not going inside, we can clean it with that. Semi-critical, we are usually using the Hicc solution, that is OPA, usually 2% glutathione solution. Again, it needs to be monitored for 14 days. We use strip test to clear for those disinfection, for making that quality control in that case of disinfection of the equipments. In case of critical equipments, they usually undergo all autoclaves, and autoclaves have quality controls inside, and they will have daily quality controls are run in those cases as well. The biological controls are used every week. So this is when we talk about this. Now, usually what we come across is cleaning practices in most of the hospitals, we will find them as often suboptimal. So we emphasize that daily cleaning of surfaces near patient is often performed poorly, and we have seen with different methods, we try to see that, try to quantify them, whether the cleaning is done properly and done or not. So we would take swabs, different swabs are taken before cleaning and after cleaning procedure. So as you can see, over absorbed table before cleaning and after absorbed cleaning, there's no difference. And terminal cleaning of rooms after patient discharge is often adequate. This has found in most of the studies that even 50% cases, the surface is not cleaned properly. So that is what we need to make things under control whenever we are having contaminated surfaces, because these contaminated surfaces, they can contribute to transmission, and they and this, when there is contaminated environmental surfaces, the transmission of pathogens is much higher. The patient having hospital-acquired infections, if cleaning and disinfection protocols are not taken into account, then the rise of hospital-acquired infections has also occurred. By serving as a source from which healthcare workers contaminated their hands or gloves, we would also take sometimes after taking out the gloves, the nursing staff or the healthcare staff, they would not wash hands. And sometimes when we were auditing, we would go and take the surveillance swabs from there. Okay, contaminated medical equipment that come into direct contact with the person can also serve as source of infection. So suppose an equipment was taken and it was not properly cleaned, say a suction, if it is done, and if we don't clean our suction bottles, that the aerosol production or the can happen in that case, and the healthcare staffs, they might get cleaning of patient care area. That is what we have to do. So cleaning of patient area, we usually define that what is the critical areas and what are the non-critical areas. In critical areas, we have usually isolation rooms where our infectious patients are kept. Infectious patients means that where the transmission of diseases there due to contact surfaces, airborne surfaces, or droplet surfaces. So those cleaning of patient area we define, like in critical care areas, we need to clean our areas every 2 hours by 1% hypochlorite solution. In case of non-critical areas, we do it in every shift. So the purpose behind the infection cleaning and disinfection protocols to be in place is that we have to make them available in such a manner that the cleaning and disinfections, they are done in most of the in a sequence, say in critical areas in every 2 hours, and in non-critical areas 6 hours. So whenever we are trying to formulate our policies, these 3 topics, they are important: classification of patient care equipments, methods of cleaning and disinfection equipments, and cleaning of patient care area. Now, daily cleaning, I've already explained that there's most of the studies, they show that a lot of areas, they're not cleaned. And that is why the training of those housekeeping staff, that is the most important part. Whenever we talk about infection control nurse, the infection control nurse, they have to have a vigorous training done around housekeeping and general upkeep. So housekeeping staff in our hospital, what we do is we usually train them once a week. Every shift, we try to cover that all of the housekeeping staff, and our housekeeping staff is huge, maybe 400, and we have 3 to 4 infection control nurses where they divide into different groups, and they take up the topic of cleaning and disinfection. Critical areas needs to be defined, non-critical areas needs to define, and how to clean those patient before the patient enters the room and after the patient leaves the room. So both the things has to be very much defined, and they need to be trained, because all will depend on this housekeeping staff. As we have seen that the cleaning and disinfection, they are the things which needs to be in control. Now, patient admitted to a room formerly occupied with patient with BRE, MRSA, or MDR, that is multi-drug resistant pathogens, they are usually at risk of acquiring the organism. So in these cases where we notify, so the trigger goes from the microbiology department that the patient grew VRE, MRSA, or MDR. So we put our tram card on that door card. We usually write that this is a VRE patient or a MRSA patient or a multi-drug resistant organism. And in those cases, if terminal cleaning of rooms were inadequate, the patient would have given the organism directly to the contaminated surface. So we try to say that these are the things which needs to be done in training, that these areas needs to be cleaned properly. So in this picture, I'm just trying to show what are the high touch surface areas which are continuously touched, or high touch surface area we call it. And these are the areas which needs to be trained to our housekeeping staff, that these are the areas which needs to be cleaned whenever the patient is moving from this ICU care setting to ward area. So this is, I've explained critical items, surgical instruments in implants. Semi-critical items are endoscopes, endotracheal tubes, and other similar items. Non-critical items being stethoscope and thermometer. The methods of sterilization and disinfections, they are common methods of sterilization and disinfection. They are heat sterilization method. We use steam or hot air oven, Okay, so and ethylene dioxide, this is called as ETO. Usually the plastic materials which go under ETO in our areas. Glutaraldehyde based formulations, they are used for scopes like endoscopes and bronchoscopes. Then wet pasteurization of 70 degrees Celsius for 30 minutes. We usually use that in our 70% isopropyl. This is used for non-critical items. 1% sodium hypochlorite solution, usually for cleaning of all surfaces. So our floors, they are cleaned by 1% hypochlorite solution. Our the bedside bed rails, they're all cleaned by, all hard surfaces, they are cleaned by 1% sodium hypochlorite solution. Phenolic germicide detergent, again used for non-critical items. Iodophor germicide detergent also used for the non-critical items or semi-critical items. And quaternary ammonium germicide detergent, they are used for the surface cleaning. So we have R2 agent, which is usually used for cleaning of these surface areas. Now, sterilization, as I told you, there are high-level disinfection, interlevel disinfection, or low-level disinfection. The items which enter tissues or vascular system or blood will flow through them, these are called as critical items. And ETO, they are done by heat sterilization or ETO. And so these comes under this comes surgical instruments or implants or the tubings. High-level disinfections, the items which expect dental will come in contact with mucous membrane or non-intact skin. These are called as semi-critical items. And these are usually cleaned by Sidex and OPA solution, endoscopes and bronchoscopes. Other similar items comes in that. In intermediate level of disinfection, some non-critical items are seen, and they are cleaned by isopropyl alcohol. This is usually thermometer. Low-level disinfections, which we use for usually stethoscopes and bedpans, and our hospital, whichever the hospital infection control committee approves, those agents are used for patient cares. So non-critical, disinfect non-critical medical devices with accepted disinfectant. So hospital infection control committee, as Upasna must have told, that these are the disinfectants which are have to be approved by hospital infection control committee whenever we are using any disinfectant. So what we do is we test those disinfectants by different methods approved by international guideline, and they are, in case of non-critical medical devices, the contact time is usually of less than 1 minute, which is said to be often effective in those cases. In case of patient care devices, if we are using, if they are visibly soiled and on regular basis, after each use of a patient, we should be using once daily. And if dedicated equipment is not available, disinfect items after using on a patient which is being isolated due to resistant microorganisms. So non-critical patient care equipments, all these 3 points are important, whether we are cleaning non-critical medical devices or patient care devices we are talking about, or any dedicated equipment, if it is not available, we are talking about. When we talk about the surfaces, disinfect environmental surface on regular basis when visibly soiled. So I'll explain it. If spill happens, then how do we clean it? That is how we have to clean it. There's a protocol. And these all are manufacturer's recommendation used for disinfectants. If you have to clean the walls, so in OT we can say clean walls, window blinds and window curtains in patient areas if they are visibly soiled. If they are soiled so much, they needs to be changed. So they need to be notified by, especially our infection control nurse. They go and tell the infection control committee that we need to change our window curtains sometimes if the splash happens or the fluids have come, or the walls needs to be painted again and again. So all these points, they are taken in account when we are talking about cleaning and disinfection protocols. Use of approved disinfectant in patient care areas if contaminated blood body of blood and body fluids is possible, and if contamination by multi-drug resistant organism is possible. So an approved disinfectant, which disinfectant has to be used in which area? Again, a hospital infection control committee usually guides the hospital what needs to be done in what cases. In non-critical areas, prepare disinfectants or solutions are needed and replace them fresh solution. So what happens, we have seen is hypochlorite solution, it has got a shelf life of 4 hours only. And this needs to be prepared freshly. So what we have trained our staff is that every shift the hypochlorite solution needs to be checked, and there's a supervisors who check that whether the disinfectant solution is made freshly or not. So there's a register kept in every area where are disinfectant solutions, if not prepared, they usually they are signed by nursing staff or TLs, we call them team leaders, which are responsible, because no use if we use an old disinfectant solution, it will be of no use. Okay, and usually this needs to be replaced. Also the protocol says that mopping solution after every 3 patient room, it should be changed. Usually because then the load, we can say the bacterial load will be so high in the same mopping solution that the disinfectant will stop working. So in that case also replace floor mopping solution every 3 patient area, and it should not be lower than if after an hour, you need to make a new solution. So either way, either the 3 patient areas or 60 minutes has elapsed, we usually change our disinfectant or prepare freshly. We also decontaminate our mop heads and cleaning cloths regularly. So what we do is after the mopping is done, usually again, what we have done is every shift will have a different mop head, and that mop head will go and into a sun-dried position. If it is dried properly, then only we will use it again, and otherwise the other. So every shift will have a different mop head. That is how we have tried to regularize our cleaning and disinfection protocol. The detergent and water are also adequate. So in non-patient areas, this is very important that in our critical areas, we have a supply of dedicated RO water only. So RO water makes it easier, it's a softener, and because the hard materials are not present in that, the disinfectants works best in those solutions. So we have made it mandatory to have in critical areas the solutions. Now coming to cleaning of patient care areas, surface should be cleaned. So this is a protocol which we are using for our critical areas. Surface should be cleaned with 1% hypochlorite solution. Electronic equipments, they are cleaned with Bacillol spray. So this is a brand solution which is having a Bacillol in it, and it contains a 2%, 75% phenol along with Bacillol solution, which is used for cleaning. So this doesn't harm your equipment. That is why we use this spray. Mopping is done with 1% hypochlorite solution, as I told, every 2 hourly. The OR and cath labs, they should be cleaned with 1% hypochlorite solution between each case, allowing a contact of 20 minutes. Why the contact time of 20 minutes is there? Because in this, the microorganisms, if they come in contact with 1% hypochlorite solution, they usually get killed. OT tables, they are usually disinfected with Tuffy. Tuffy is a ready-made towel which is available, which is again having hypochlorite solution. So the OT tables, they are usually disinfected with those Tuffies. And thorough cleaning of OR and cath lab should be done every weekend with 1% hypochlorite. So after the new guidelines from CDC had come that fumigation cannot be done, what we do is we have a fogger in which 1% sodium hypochlorite solution is made, and we fog our OT theaters every week. And after that, the surveillance swabs are taken, which shows us that none of the area is contaminated, and those areas are cleaned by all methods. So this is what we have done for critical areas. In the non-critical areas, the surfaces should be cleaned again with 1% hypochlorite solution. Electronic equipments, we also clean it with Bacillol spray. Mopping is again done with 1% hypochlorite solution, and cleaning of areas after every shift, it is done. So the difference being that regular cleaning of critical area is done by fogging, which makes a difference from non-critical areas. Fogging is usually not done in non-critical areas. In what we try to terminal after every patient leaves, we do a terminal cleaning of those areas. These some methods which are available in some areas are, we can do it with UV lights. These automated mobile UV lights, they are available. And the range which use for disinfection of rooms, we can say is UVC, which is 254 nanometer in range. They can be placed in patient rooms after patient discharge and terminal cleaning has been performed. So this is what it helps is that we don't have to close our rooms for much areas. That after fogging, usually 4 to 6 hours, the rooms are usually clean. If we disinfect our patient area by UV light, it can be opened as after the disinfection process by UV light is finished. This, the advantage is that it kills all vegetative bacteria and also kills spores. And it's significantly what we had done is in our area, we had done a project and where it significantly reduced bacterial counts in patients' rooms. And it is easy to require relatively short cycle times. Short cycle times means that somebody is trying to suggest F5, which is not working again. Sorry, folks, what I'll do is I'll share my slides with Tripti in net after I finish this and I take questions. In the meantime, I'll finish so you will be able to see the full slide in that case. I'm sorry about this. Okay. So improving cleaning patients' practices, what we should do is educate our housekeepers regarding recommended cleaning practices and the importance of following hospital cleaning policies. They ensure compliances by housekeeping staff with cleaning and disinfection procedures, develop policies regarding which patient care equipment and environmental surfaces are to be cleaned by housekeepers or nursing staff. So this is what I have to say about cleaning and disinfection protocol. What we will do is right now is take up the questions and try to. Okay, so the question here is fogging to be done in a closed room and then it should be closed for 4 to 6 hours. Yes, fogging, if Virex solution, it all depends which solution you are using. We are using Virex. Virex has, it is having phenol hypochlorite solution in a way that these small particulates we can say, they are released in the room. It should settle down, it should have a contact period so that it works on those surfaces and then can be used. Okay, so that is why it is used and it has to be closed for some time, because if somebody enters in a room which has sodium hypochlorite, it is hazardous material, he will breathe that material, and that is why we close it for some time, let it settle, the fumes get settled, and the air becomes breathable, and then only we open. That is why we take 4 to 6 hours after fogging. Somebody has asked Dr. Shankari that UV light have a short period. Okay, so UV light, that is why UV light has a short period, because after UVC has done its work, okay, we then it does not need any residual material. Okay, we can say it's a residual material, and then we can go for opening up the room as soon as the UVC has done its work. Okay, so that is why it is a short cycle procedure. Another question is coming up is, Madam, UV light duration after cleaning, it doesn't require any cleaning period, any duration. UV light has a duration of 20 minutes. Okay, and after that we can open the rooms for, since it is disinfected at their time, there is no lag period, we can open the room at that time only. Another question coming up is, glutaldehyde is being discouraged. Discouraged by what is that? Discouraged. Glutaldehyde definitely is discouraged, but we can use 2% glutaldehyde OPA solution, which is an approved material in our case. Fogging is advised according to CDC. Fumigation is not allowed. Fogging is advised according to CDC. That's a correct thing. We can do a fogging. Glutaldehyde ki jagah we can use OPA, opaque glutaldehyde. Okay, that is not barred from NaBH. We can use that. How to disinfect modular OT? Are you talking about robotic surgery? Yes, we can. We have special disinfectant solutions which are approved by manufacturer's guideline. In that case, we can use that Bacterial spray to disinfect robotic surgeons. Infection control in molecular diagnostic labs like virology labs. So in this, especially in case of molecular diagnostic, I would suggest that 1% hypochlorite solution does not work. Usually the recommended is 5% hypochlorite solution for virology lab if we are dealing especially with COVID areas. Okay, so in that case, 1% hypochlorite solution is not used. 5% hypochlorite solution is used. Is surface swabbing and cultures still recommended? No, surface swabbing and cultures are not recommended, Dr. Gomti. It is only recommended in case of outbreak. So suppose, or in case of an MRSA. So I'll share my experience in my hospital. If an MRA case have come, then we will take cultures from all our nursing staff that have been taking care of that patient. And then we will do a tracking of that if any nursing staff is positive with MRSA, we'll take out that nursing staff from that area. It will go to some other non-patient area till she's treated by the solution. Okay. For UV light area of a room, it all depends that how many UV lights you are using. If you are using 4 UV light UVC area, usually a 12 by 15 by 15 room is enough to disinfect for 20 minutes. So coming to the topic of hospital infection, a very important topic, especially when we talk about COVID, that outbreak management. Initially, outbreak management was said to be only for areas like having, if any outbreaks of, say, some microorganism have covered. So I have seen outbreak in my NICU, that is neonatal unit, Pseudomonas bituta. We had it 4 years back. And I will share some good points regarding that how we controlled our infection control in Pseudomonas bituta. Now coming to the outbreak management. Outbreak management, just to make you understand that it is a responsibility of prevention and control of infection in hospitals which lie with infection control team. And the infection control team, as we have already discussed in the morning lecture, that it consists of infection control doctor, infection control nurses, and when necessary, we should also have a unit head or chief executive, or we can say a chairperson or medical director, whatever we want to say, some representation from a higher administrative person. Infection control, as advice, should be available 24 hours a day, but that is very difficult. It is practically not possible. So we work through infection control linked nurses, we can say, or we train our infection control, at least critical care units, where the team leaders can also chip in if infection control nurse is not available, especially during night time I'm talking about. Outbreaks of hospital infection vary greatly in extent and severity, range from few cases of urinary tract infection to larger outbreak of food poisoning involving hundreds of people in one case, say maybe of diphtheria. So it can be as small as an outbreak of a urinary tract infection. It can be an outbreak of food poisoning in which a patient had due to supply of even food from the hospital or from outside had come to the hospital care, or it can be in this COVID area, something of a pandemic kind of a thing in which most of the hospital has to be a COVID special area or a COVID wards, we said, or we said COVID hospitals. So in referring to that terms, it can be a smaller outbreak, acute outbreak, a chronic outbreak, or anything as large as COVID area. There must be one person with the expertise to decide on a major outbreak is occurring. So usually infection control doctor, that is a consultant microbiologist, it takes a lead role in identifying and managing major outbreaks in hospital infection. So the most important point here is that recognition of outbreak is important. In some outbreaks, this may be immediately obvious, like outbreaks of diarrhea. Suppose a unit started having a diarrhea, and especially it happens from RT feeds in critical areas. Or it can be a patient occurring in patients discharged from short hospital stay, say after childbirth or day surgery. So patient of LACS, they will come back, and a patient having surgeries in particular OTs, they might come break as hospital acquired infection. So it could be anything of an outbreak, and it may go unrecognized for some time. So I will share one detail that we had an outbreak of Mycobacterium in our case. So one particular OT, from there, the water which was used for mopping was having mycobacteria, and we started having a mycobacterial outbreak in that case. But it was recognized, we cleaned it thoroughly, and we could identify that outbreak very easily. Many outbreaks are first detected by microbiology laboratory due to increased isolation of unusual pathogens. So by definition of an outbreak, it is usually clear that if an unusual microorganisms start coming in a hospital setup, that is an outbreak. If we are having, say, multi-drug resistant organisms, in this case, we can say CROs, that is carbapenem resistant organism. If suppose one or two is a norm in a critical care unit, and suppose I started having multi-drug resistant organism to the tune of 4 or 5 or maybe 7, then we call it as an outbreak. So the laboratory must report these suspicious cases to infection control doctor as soon as possible. But usually the microbiologist is the one who is always reporting those outbreaks. The initial investigation is very important. If an outbreak exists, the infection control will make an initial assessment to determine first the nature and size of the outbreak as it is defined to the hospital, whether there are community implications or whether the ICT can cope up with infection and control. If the outbreak is likely to be of major importance, so it is a minor importance or a major importance, that is more important to us. So procedure for dealing with an outbreak, major control group is usually formed. This major outbreak control group, we call it as MOCG, will meet according to the need in the acute phase of outbreak. The functions of MCOG are to take all necessary steps for the provision of appropriate continuing clinical care of the patients, staff and visitors during an outbreak. So major control group will take of all the three things in account, whether the patient is having an outbreak, a staff and the visitors. We should always have adequate communication channels to establish all who need to be keep informed about progress and controls. This includes nomination of one individual with the responsibility of making statements. So number of people should not be communicating. It will create a lot of chaos. So only one person is designated so that they can have an adequate communication. Then we should also clarify resource implications of outbreaks and its management, and they are achieved through adequate supplies and staff. Then we should also have coordinated policies, decision of the investigation and control of outbreak, and ensure implementation. Responsibility will be allocated to specific individuals with accountability for action. So in this case, if I could talk about context of the COVID, all the policies were given usually by the ICMR. All the major policies that needs to be followed by the government guidelines, and for internal methods we would formulate small guidelines so that the operations of any hospital should not be hampered. We can consider the need of outside help and expertise. Suppose I don't have enough facility of PCR, I will outsource that test to other. Okay, so in that case, outside help and expertise is needed. We also need clear instructions for the information of ward staff and others, like we can say in this COVID area again, whether this ward is a COVID or a non-COVID area, we need to identify and also tell our these staff members that this is what the area is about. We also agree for arrangements of providing information to the patient. We should always stick placards or always take some kind of information placards that this is a COVID area or this is not a COVID area. We should also meet frequently, daily, and review progress of an outbreak investigations. And meetings should be in written agendas, mission, and action notes. So when we talk about major outbreak control group, this is for them that usually a daily review, like in basis of COVID areas. I'm sure most of the hospitals were tracking how many COVID positives are there, how many staffs are positives in that case, and review progress of each outbreak was happening in this COVID. We also defined the end of an outbreak. We will not say in this case end of the outbreak has occurred, but yes, if we talk about Delhi, the cases have startly going down. So the ward which might be of 2 wards were there, now only 1 ward is there. And we also evaluate lessons. If any gaps were there in caring of our patients or staff, we always evaluate and try to take those learnings in that hospital, major hospital outbreak group, and also produce reports within 48 hours. And these lessons are usually circulated inside our hospitals and also inform others about this. So majorly, if we talk about this, is all the work to be done by major outbreak control group. Now, coming to the members, who should be the members of this major outbreak control group? Usually head of the nursing, chair of infection control committee. In my case, it is an OT medical director. He's heading the unit, and also director of emergency services. In my case, because most of the footfall, if you see in COVID areas, it will usually land up in the triaging area or the emergency wards, because the patients then becoming sick, they would land up in that area. So these are the important members. The additional members can be head of critical care, Department of Medicine was involved, laboratory sciences head is involved, the catering manager is involved, because how we supply food to a COVID area need to be identified. So we identified our catering manager. We also identified CSSD manager, like what were the things which will go into again recycling and what will have to be discarded in case of COVID, that need to be defined. Housekeeping manager, the cleaning protocols, cleaning and disinfection protocols. So we have to take a housekeeping manager into account. Hospital chief pharmacist was involved. We all remember an era where remdesivir was not available. In most of the hospitals, it was like available in the market. So chief pharmacist was involved in this case. The supplies officer was involved, or we can say a store manager involved, because N95 masks and the number of adequate PPs has to be adequate. They need to be there. So our supplies officer was involved, and representative of any department. So any other department, say if we started seeing cases, like in this example, I will give you the ENT and ophthalm was involved. When we started having more cases of mucormycosis, this people from the HOD of ENT and ophthalm was involved in members of OCG. So the members can increase or decrease according to our needs, and according to identification of outbreak, we should be looking at it. The patient care, the responsibility of any continuing care of infection patients lies with the consultant under whom the patient is admitted. So we should see whether any active or passive immunization needs to be considered in this case, or any antibiotic prophylaxis to be considered. Protective isolation for susceptible individuals were considered. Isolation facility, adequate number of rooms, isolation of ward, and isolation policies to be implemented. This additional fixed facility, if any other, we have to refer our cases. So sometimes if the facility was full, we would have to consider any areas in which the patients can be referred if very sick. Then policy of what is the patient admission policy, transfer and discharge needs to be defined. Like in COVID, what we did was that the mild cases, they will not be admitted. The moderate, which required oxygen saturation, which were below 95, would be admitted. And then patients who required critical care. So all these are again the policies needs to be defined for any outbreak management. What is the patient admission criteria? What should be the discharge? When should be the patient discharge or transfer to other areas? Policy on movement of patient and staff within and between hospitals defined. So when COVID was happening, the wards were identified in case that the COVID patient should not cross a non-COVID area. So specialized lifts were defined in that case. The staff which be taking care of our patient staff was defined, and it needs to be circulated or communicated to the whole area. The visiting arrangement need to be defined. So as soon as the COVID came, the visitors policy had been redefined in this case. Initially, and during the visiting hours, the patient's attendant could visit. Now in critical areas, we don't allow any patients visiting. We always allow only on virtual WhatsApp call they can do, or a virtual arrangements needs to be done. So again, are defined according to outbreak policy. We have also defined our visiting or visitors in our hospitals. Expert advice implemented. Anything which came from the experts, say in this case, the government policies would have been employed. And when additional nursing or medical staff considered, when the nursing started having the infections, the additional staffing has to be done. So we also defined that. So all this is a responsibility of, again, our hospital, that when an outbreak is happening, what things needs to be done in that case. Then communication was very important. Since we did not have the visitors in our places, so the communication to the patient has to be done. Sorry, the communication to the patients need to be done, and they could talk to their patients who were inside the hospital setup, and what is the progress of the patient, how the patient is doing, when will the patient discharge, this communication lines. And in triage and our critical areas, we had monitors there where we could take our patient, and in between they could talk along with our doctors. This is how the communication system was enhanced according to the need of the COVID. Then a member of MOCG usually accept the responsibility of ensuring. So what communication needs to go outside the hospital has also been monitored, because a lot of things were happening in that area. A lot of even the doctors were beaten in some cases. We all remember in the second wave, because the patients' beds were not available. So the communication has to need to be a very strong in that case. What is the situation that needs to be explained? And usually the disease, if we cause a disease defined, usually a consultant microbiologist would communicate to the higher management, and then they would further manage it. Now, the coming part to the management, which is the most important part from our hospital side. To need that management, any additional staff, it was required in that cases. So we created a pool of locums, you can say, or we created a pool between different healthcare groups where the additional staff could be taken from a facility which were not being used, or they could be taken from areas where the less of patients were admitted in those areas. So a need of additional staff was taken into account, maybe a nursing staff, a medical staff, clerical, laundry, CST, any additional laboratory facilities considered. So we have to keep on up our laboratory facilities. As the sample size started becoming bigger in second wave, we have to keep up with those laboratory facilities also. Isolation facilities were defined. Initially, negative pressure rooms were there, was created, and then we could not have the isolation facilities. Then we started cohorting our patients in that case. So patients with the same disease has to be kept with those patients. So if I don't talk about COVID, say a patient of chickenpox is admitted and another patient is admitted. If I don't have an isolation facility, what I will do is I will keep two chickenpox people side by side and can share a nurse in that case. So isolation facilities have to be defined according to the resources available, according to the infrastructure available, according to the nursing capacity you have available. So this is how the management of any outbreak needs to be also planned. The effect of planned admission consider. I can take only infectious patients of tuberculosis, say if I take an example, I can take only 5 tuberculosis patients in my hospital because I have 5 isolation rooms, negative isolation rooms, where my patient can be taken. So that is called as a planned admissions considered. Okay, and the admission officer usually are bad managers. They are informed that look, and they have a trigger mechanism. Look, in my facility, 4 available. I can take 1 more patient. So the bad managers are usually informed in the case of the management. The need for increased secretarial or communication facilities. Yes, we did it in case of COVID, that the communications were increased during that time. Adequate supplies, including medicines, were also taken into consideration. Staff protection and antibiotic prophylaxis. Special measures for staff protection. So in first wave, I remember very clearly, every staff was given an antibiotic prophylaxis of chloroquine, which we later find out that it was not required. But during that time, antibiotic prophylaxis was just an example that to protect the staff, we should be giving antibiotic prophylaxis in that case. Okay, then catering procedures need to be defined, how we cater to how the food will be served to those patients which are infectious in nature. So they usually wear the PPEs, proper PPEs, when they are serving food. And every patient will be marked for infectious patient, that this is this kind of a patient, and the training of kitchen staff, or we say stewards also, we take place in a manner where they know that PPEs needs to be worn when we go into that room. Housekeeping procedures, I told you, in cleaning and disinfection protocols, the procedures were defined. Nursing, medical and paramedical staff was formed, and especially in this case, I would call special arrangement required on death of infected patients were defined. So we all know when the COVID deaths were happening in these cases, the swabs were taken, the RT-PCR has to be done in that case, whether the patient has died of COVID or not. And the government also came very heavily. If the patients who were not having RT-PCR and had deaths, they had to get their RT-PCR done, and then only the last rites were informed. So this is how defined any management of any outbreaks needs to be done. And not just in COVID, but any other areas, the deaths is usually not important. But in COVID, yes, we had protocols about the COVID deaths also. Coming to the investigation part, usually who is responsible for coordinating epidemiological investigation? I will not talk about the COVID here. I will talk about the if an outbreak happens due to hospital-acquired infection. So the responsibility of collection of specimens is usually by infection control nurse. Suppose a MDRO, or multi-drug resistant organisms, outbreak happened. So we need to have all epidemiological parameters are closed. What was the age? What was the any procedure done? And then we also see that what is the what is the environment in which this happened. So we collect appropriate samples according to it, and this is usually the responsibility by the infection control doctor, who will define what epidemiological investigations needs to be taken in that case. The outbreak number need to be allocated. We have to define whether 5 cases are there, 6 cases are there, or the number is increasing or decreasing. The case definition had to be made for clinical or microbiological criteria. So case definition simply means who will define, and that we can define this is an outbreak and this is not an outbreak. So we need to have a clear definition or a case definition to define an outbreak management itself. The engineers are involved, or the food samples are examined. Why the engineers are involved? Because when we have to see which kind of an outbreak is there. So according to that, transmission-based precautions we need. So if it's an airborne, we have to keep it in a negative pressure room. If it is an immunocompromised patient, we will keep it positive pressure room. So engineers usually try to change the rooms according to the need we have in outbreaks. The food samples need to be examined. Suppose it's a diarrheal outbreak. So those food samples needs to to be taken, and that is why the investigations is required in that case. Environmental samples are taken if an outbreak of infectious multi-drug resistant organism. So we usually take environmental sample from the patient's bedside, usually from the suction catheter, the ventilators, if the ventilator, or bed rails, or even the saline solution sometimes we take as an evidence for environmental samples. Samples need to be transported sometimes to the reference laboratory if we have to define any outbreak which is of variety, that where we can't test in our hospital facility, we might have to refer. So like, I will give you an example again with COVID, that genomic sequencing is not done in many of the RT-PCR is done in many hospitals now, and even the standalone labs are doing it, but but genomic sequencing is done only by NCDC here in Delhi if we talk about, or it is done in ILBS, or it's sent to National Institute of Virology, and some more centers are defined. So in that case, if we have to differentiate between Omicron and other variants, the genomic sequencing has to be done. So to defend that, all the positive cases, they were referred to reference laboratories, whether this is a case of Omicron or other variants. So that is what the investigation simply means here. The epidemiological studies in progress need, and further studies needs to be considered as the cases will come up or go down. Follow-up contacts, like contact tracing was very, very important if we talk about COVID here. Follow-up contacts of infected patients were taken. So we all know the societies were sealed, and every patient who came positive initially, the government would go and try to isolate that house so that the further spread does not have. This simply means follow-up contacts or contact tracing has to be done in case of an infectious patient. If we don't talk about COVID, but we talk about some other cases, say Vibrio cholerae cases come to me. Suppose 2 or 3 Vibrio cholerae cases have come, we would like to go into that address of that patient where these cases have come up, or the further cases have are coming. So follow-ups contacts are important in case of an outbreak. To stop an outbreak, we should have a follow-up contacts in that cases, right? Further, microbiological or serological screening of apparently non-infected people have to be considered for patients, relatives, visitors, for staff, other contacts, and a list of number of infected patients. So microbiological screening, I say most of in initial days, ICMR had one of the column that patient who had come in contact of COVID positive, they can also undergo microbiological screening. In serological screening, I would suggest that COVID antibodies were taken into account, and now for a non-infected people also, so that to see what are the titers where they are heading to. After the doses were given for vaccination, the titers are still being checked, so seeing what are the antibody levels, and they can be for patients, for visitors, for staff, and other contacts. So serological screening is also important when we are tracking our outbreaks. Then coming to the most important part we should be talking about here is the control of infection control for any outbreak. So important aspect is adequate number of isolation rooms and cohort nursing should be available. Need of active or passive immunization. As I say, booster doses are not available. Any need for antibiotic prophylaxis. So people were given prophylaxis. Protective isolation for susceptible patients need to be considered. Isolation policy for this conditions need to be defined. Disinfection policies for domestic procedures, like we all knew that Lysol was so famous when we were having home quarantine, and isolation policies were implemented according to the severity of the disease. Policies were defined for new admission, discharge, and transfer of other wards and hospitals, movement of patients, and any special precautions required in that case. So these were the important points which we should be taking into consideration. So I have most of the time deal with COVID-19 also, but I will just to rephrase that for COVID-19, what were the things which were required in this? We had an ICMR form, if we talk about investigation, where the test initial details, personal details, specimen formation, referring agents were used, and patient category was also defined. So there were different categories, which were this ICMR forms, according to which we would do the testing part. Then there were medical. Section A consists of different categories and section B consists of medical information. Clinical sign and symptoms were important. Initially, in first and second phase, only symptomatic people were being tested. In third phase, asymptomatic people were also tested. Any pre-existing medical conditions were important, like COVID, hypertensive, or diabetes, like we all know. They were important to consider. Any hospitalization details, any different details. This all had ICMR form, had all this, and where the details were defined. We also defined our biomedical waste management according to biomedical law. Reference to red bin, again gloves, and everything else would have gone into the yellow bin. And in the last stages, even the red bin, this was changed to all yellow bin, and all caps, gowns, COVID, whatever we saw in doffing, they would go in yellow. Rational use of PPEs were defined. So area screening or COVID area screening will have COVID suit, N95, goggles, face shield, and gloves. Non-critical areas will have N95, and non-COVID clinical area would have N95, and non-clinical area they would have. So we had policies according to this only, that 3-ply mask will be used in non-clinical areas. I will go again into details of donning and doffing. Donning techniques were 1 to 12, donning of PPEs, surgical scrubs, perform hand hygiene, gloves, hazmat suit. We also had shoe covers and respirators, goggles, surgical hood, face shield, lead apron, disposable long sleeves, surgical kind, and second pair of gloves. So this was a special sequence which we have used in COVID areas. This again, doffing technique, 1 to 19 were defined, say gloves, reporting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So doffing, we had defined our areas, the order of removal, some again, gloves, gowns, then eye protection, then respirator, and then wash hands. This is just a repetition of what we have already seen. The most important thing which I would like to suggest in this slide is that risk assessment was done for each and every staff which we were tracking. And we had a COVID policy, and there this risk was defined according to the exposures they have come under the criteria. So if the patient, if the staff who is exposed to COVID positive and he is wearing or she is wearing the whole PPE. PPE means the hazmat kit was worn along with N95, then it was a no risk thing. And we would try to pacify our staff that even if you have come in contact of these cases, you have no risk, and no quarantine was required in that case, and they could resume their duties as ever. If the staff was wearing a 3-ply mask and had not come into contact or was not directly involved, then it was a low risk. So we would say that you have to identify if any symptoms have occurred. In case of medium risk, no aerosol but without PPE. So no procedure was there, but the staff was not wearing a proper PPE. In that case, in medium risk, again, we would take a leave, give them leave for 1 or 2 days so that they can see for their symptoms and then resume their duty. If the staff was not wearing PPE or came in contact with COVID positive along with not even wearing N95 mask, those staff was defined as high risk and they would be quarantined in that cases. So this was the most important part, I think, feel that every hospital should have done risk assessment and their exposure management of staff. So according to that, only the quarantine policies were there. Now in second phase, till second phase, 14 days quarantine was done. Sampling was done in RT-PCR if symptomatic 5 to 14 days. And after 14 days, they would join work if asymptomatic and no testing. This changed to Omicron by government guidelines. 7 days quarantine was needed. And no testing is required if the staff was non-symptomatic. Home quarantine had its own implications, and they have own guidelines that there should be a separate room with attached toilet. They should wear surgical mask, dedicated person assigned to interact. Okay, not every person from the home should be interacting, only one person. And household bleach was used for disinfection of surfaces. Especially old age people along with comorbid conditions should have been away from vulnerable age group, and 14 days for close contact. This was initially in the first period, and then this was changed that nothing is required in case of prophylaxis. Disinfection handling even after home quarantine. In case of hospital, we would disinfect by 1% hypochlorite solution for 30 minutes and then give it for laundry. In case of home quarantine, we would wash it with Lysol or with hot soap and water. Disinfection of every linen needs to be done. And dead body management was important. All holes had to be sealed. COVID sampling need to be done. The wiping of the body with 1% hypochlorite solution was done. That has to be packed in body bag and disinfect body bag. So this was a major outbreak and a pandemic which is going on. And these were the guidelines for dead body management. That is what I have to say about this outbreak management. This is all from my side for outbreak management. We have one more topics. I will not take questions. We are running late for our because of the technical glitches. I will directly go into the next slide presentation of into my next presentation, that is needle stick injury and spill management. Sorry. So needle stick injury, it is an important aspect, and any percutaneous injury from a needle or instrument contaminated with patient's blood, body fluids, or other potentially infectious material, it's called as needle stick injury. And the commonest cause when we say is that improper segregation, the recapping of needles, the transportation, reuse of needles, or banding of the needles. These are the important causes of commonest causes of needle stick injury. What happens? But the more important question is, what happens if you get exposed to needle stick injury? And what I'm supposed to do if I get needle stick injury? So the first thing first is, I would say that don't panic even if the needle stick injuries happens. We have to first wash off with soap and water, encourage bleeding, never squeeze, expose mucous membranes, including conjunctiva, and wash copiously with water, and find out the source of the needle. This is what we should always do. Okay, and always tell somebody that needle stick injury is important. In my hospital, it's a protocol that if a nursing staff is there or a GD or a housekeeping, we usually tell our nursing supervisor or team leader, whoever is present, that the infection, the needle stick injuries has happened, and have to show that what is the extent of that needle stick injury. This is important because we have to apply an exposure code in that case, and whether the patient, the source is known and unsourced one, that is also required in that case. If positive, then we have to take treatment of prophylaxis as per doctors. If negative, then usually we inform what to do. After the needle stick injury happens, we asked the staff who had needle stick injury, they go to an EMO. Okay, and there's a needle stick injury form which needs to be filled up, where the details of the source has to be given, whether there's a patient or it's an unknown source. Are you immunized with hepatitis B immunization? Then you have to give your blood testing for anti-HBs, it's antigen. antibody titers, your HCV and HIV, so or viral markers, because that is the important source of needle stick injury that needs to be done. Then follow treatment advice as per physician on duty, and complete the needle stick injury form, incident form, submit to ER or the infection control nurse. This is the protocol which is given in our hospital. The investigations that are flow which is done is, I'll take the questions later. There are certain questions in the chat box. I will take them later. Follow-up period for the investigations usually is defined, and it is defined as 0 day, the day the injury happened, 6 weeks, 12 weeks, and 24 weeks. I would say 24 weeks is the most important week for the follow-up period, because it is then if any needle stick injury, any viral markers which we are testing has happened due to exposed patient, they usually manifest between 12 to 24 weeks. But usually what we have seen in our practice is that people don't turn up for the follow-ups after 0 to 6 weeks. So I would suggest if any needle stick injury happens in your hospital setup, as being hospital infectionist, as you should always try to have a follow-up. All nurses should be vaccinated. I hear the word used is nurses, but I would say all healthcare workers should be vaccinated against hepatitis B, and it should record be maintained by the copy of infection control nurse. So all hospitals should have their vaccination status according to their vaccination policy. The vaccination schedule for hepatitis B is 3-dose series. Dose 1 now, 2 second in first month, and third dose after 5 months. So 016 we call it. Okay, and this is given intramuscularly. The investigations which needs to be in our vaccine, I'm sharing the vaccination policy of Max Healthcare here only. I don't know about the other infection control people, how they are managing, but I would suggest that hepatitis B, influenza, and typhoid, the tetanus should be given at least to all the hospital working staff. Okay, so in our hospitals, hepatitis B, it is given for doctors, nursing, microbiological, paramedics, and housekeeping staff. Only F&B staff is not enrolled here, and outsourced staff means whoever is coming on locum basis, we don't involve them for hepatitis B. Then influenza, it is given for doctors, nursing, microbiology, microbiology, paramedics, and housekeeping staff again. Chickenpox needs to be given especially to the nursing staff, because they come from the area where the chickenpox, if not had taken, it should be given. We have seen a lot of nurses, they land up when they come for these jobs around 20-21 years, they do get infected by chickenpox. So we have made mandatory for all our nursing staff to be vaccinated against chickenpox. Then there's another vaccine which is called as typhoid. It is usually given for microbiological staff and F&B staff. It needs to begin, and outsourced staff. We usually don't give typhoid vaccine. We usually try to find out if they are not having diarrheal diseases and all. Meningococcal vaccines, it is must for our microbiological staff, because we do come areas where the infectious phase we can come across. And the dosage schedule is given as such: hepatitis B 3, influenza 1 every dose annually once the new variants come. Chickenpox for our nursing staff, 1 given in 2 doses, second dose after 4 to 8 weeks of the first. Typhoid vaccine is given every 3 years. Meningococcal is given 1 dose every year. So this is our vaccination policy. So whenever we talk about needle stick injury, we should always be talking about what is the vaccination policy of my hospital. What happens if there is a hepatitis vaccinated, unvaccinated person, if gets exposure to hepatitis B or healthcare management? So there is a two-way. If the healthcare worker, it is vaccinated, we see, we give the testing for antibody titers. If antibody titers are less than 10, then more than 10, then nothing needs to be taken, only additional TT source fee vaccine be given. If the staff is not vaccinated, we should give immediate vaccination of by human immunoglobulin, that is 0.6 milliliter per kg. Okay, if it is and less than 10 international unit, and the patient was hepatitis negative, then if less than 10 is there, we could booster dose of hepatitis. If there is unknown source and the titers are also less than 10, we also again the booster doses. If the patient was positive, then completes and the titer was less than 10 along with immunoglobulins, we will also give booster dose. That is the protocol which we follow in our hospital, and this is also the protocol which is given by WHO. The follow-up action of hepatitis B positive source should be test should be exposed against hepatitis antigen and anti-BS levels. Appropriate prophylaxis should be decided on. Repeat HBs antigen after 3 to 6 months, or I say after 12 for 24 weeks also. And usually a gastro reference is given because these are the people, those who are expert in their field and can advise on any symptomatically if your staff is exposed or coming up any signs. Post-exposure prophylaxis for hepatitis C, usually we have to again determine a source, but no active prophylaxis is there. Immunoglobulins are not effective. This usually interferons are also not recommended prophylaxis. What we usually do is a blood test of HCV RNA should be taken along with LFT, KFT, CBC, and then repeat LFT after 4 weeks. Again, a gastro reference is important in this case. So if source was HCV positive, then expose anti-HCV and baseline LFT is taken, internal medicine consultants is taken, and we keep on following our staff for 24 weeks. In case of post-exposure prophylaxis for HIV, now this is important. Now, post-exposure prophylaxis is an emergency medical response that can be used to protect individuals exposed to HIV to be given as soon as possible. Common side effects include anemia, nausea, peripheral neuropathy, neutropenia, and myopathy. The drug regime according to the HIV is as such, and usually they are experts, so they would say that what is the dosing schedule. So we usually leave it to our internal medicines how they will during the post-exposure HIV prophylaxis we should be given by them. So if any, so in our case we have encountered our staff who was HIV, who had come across a patient needle stick injury who had HIV, and even the viral load was high in that case. So we had given HIV prophylaxis, and believe it or not, it was more difficult for that female to swallow those pills rather than not taking it. But we went ahead and gave that exposure prophylaxis to post-exposure prophylaxis to our patient, to our staff. Under this is safe needles and safe lives. It is the law. So needle stick injuries, they are usually a lot of things goes when needle stick injury happens. It's a mental trauma to the staff. Okay, it is a cost to the hospital because a lot of tests needs to be done and follow-ups needs to be done. So it is better to prevent any needle stick injury rather than giving exposure prophylaxis or post-exposure prophylaxis for needle stick injury. That is what I would suggest. Then there was a spill management system, and there are two types of spill management, minor and major, I would say. And categories we define for spill management policy is blood and body fluid spillage, chemical spillage, biomedical spillage, and cytotoxic spillage. We classify only blood and body fluid spillage into minor and major spillage. The other spills, that is chemical, biomedical spill, and cytotoxic spill, they will go essentially in major spills. In minor spills, we call minor spills if the volume is less than 30 cc, and 30 cc is water, one vacuum actually. What we do is we have spill team. We also have spillage kit, which is kept in every hospital ward, the ward of hospitals in every areas. And this spill kit will have sodium chloride solution, will have a yellow bag, will have gloves and a gown. And what we have to do is we have to take out that spill kit. If a minor spill is there, we pour it sodium hypochlorite solution per dilution. We call our nursing supervisor of that area, and we cover the area especially with tissue papers or with newspapers. We wait for 20 minutes and wipe and ask our housekeeping staff wipe and dispose those tissues in yellow ware wearing proper PE, and then fill up the incident form. This is what a minor spills needs to be done. Some cases a spot spill is also defined. That means if you're working in a laboratory setup and a drop of blood gets spilled in that case. In that case, you just take an alcohol swab, wear a gloves, take an alcohol swab, wipe it and put it in the yellow bin. Go and wash your hands. That is what is required. In case of minor spills, again, there's a spill kit in which you have to pour sodium chloride solution, hypochlorite solution, which is 1% in nature, and that you have to pour it and clean it accordingly. For major spills, spill team, there's usually a spill team which is involved. We have a central number where in my case it is 8224, but you can define your own spillage way how to do a major spill. Usually a housekeeping supervisor or housekeeping head should be involved in the hospitals if we are talking about major spills. And major spill kits, it's called as hazmat box. It has got the materials like sand, it has got whole PPE suit, it has got absorbent papers, it has got hypochlorite solution, and they have gum boots, they have heavy duty gloves. This is what a spill kit for a major spill kit should be defined. And you should always ask them to wear personal protective equipments. Always try to place tissue paper if you have, and whatever absorbent material you have, whenever a major spill happens, you have to put it on that spill and inform your spill team. And the other thing which you should be doing is also restrict that area through chairs, or you can put a board there that a spillages happen, so that that spill which is there does not expand to much of the areas. You should also inform any members which is close to your that spill, that a spill has happened and you should not cross that area. Then the spill team comes, they have the spill kit, they will again pour sodium chloride solution if it is a blood and body fluids, and they will inform, wait for 20 minutes and again fill up that incident form. So in our case, we just define on the basis of volume, the small and major spill, and the management is done by a central team of housekeeping or a local housekeeping team. That is the difference in case. You can also make the same protocols where nursing supervisors and the housekeeping members, they work in together to have that spill management done. So this is all from my side about the spill management and needle stick injuries. I can take up the questions now regarding the whole of the workshop. Whatever the workshop we have here, you can type your questions so that we can see.